Hello. Hey. What's the first slide deck? It's 10, right? Get going. Ready. Stuff I have to say is that it's keeping stuff. Yeah, that's fine. Just beginning or after. Thanks. All right. Excellent. Let's get started. Good morning, everybody. Great to see you all. I'm Dr. Evan Lipson with the Melanoma and Skin Cancer Program at Johns Hopkins. So it's great to be here for this first, what I hope will be not the only event, co-sponsored by AIM at Melanoma and the Johns Hopkins Melanoma and Skin Cancer Program. So thanks to everybody joining in person and everyone joining online. I just want to give you a brief overview of us as a team. We are the Melanoma Skin Cancer Program here at Hopkins. And there are a lot of us, as you can see on the screen here. There are actually multiple of us that are not on photographed, but we are a big. Am I doing wrong? There we go. We are a big group. We are dermatologists, pathologists, surgeons, med-oncs, radiation oncologists, radiologists, pharmacists, nurses, navigators, research coordinators, social workers, therapists. The list goes on and on and on. We are a big group. We all work together. We have 3 general missions. The first one is to provide world-class patient care for patients with melanoma and skin cancers, support them and their families. Second is to discover. Part of what we do is research to understand what's done to better understand disease, better help patients and their families. There we are. And the third is to teach the next generation. So we realize that the foundations that we are laying are going to be built upon by the generations that come after us. And so we are teaching the folks coming up behind us for that reason. So I'm going to tell you a little bit about each one of those. So how do we provide world-class patient care? Well, we see several hundred new patients every year. And when we see a new patient, we discuss that patient's care with the entire group. So we review everyone's case as a team, and we come up with a consensus recommendation. Sometimes those consensus recommendations are informed by research studies that have been published from international collaborators. Sometimes those are based on experiences that we ourselves as experts have had. Sometimes we recommend standard therapies. Sometimes we recommend that patients engage in experimental studies, clinical trials, to try to move the science forward. We make every effort to provide holistic care. That means we have colleagues in rehabilitation and nutrition and social work and counseling. We make every effort to make sure that the patient is cared for as well as their loved ones who are supporting them. We have financial counselors in this world of financial uncertainty. That's important. We provide language interpretation. We provide telemedicine options so that patients don't have to travel back and forth to our campus every time. We also try to share care with local clinicians when we can. So if somebody needs to be evaluated from a colleague of ours who works in the community, we try to make that happen. And so that everybody's on the same page, we share information as best we can. Let me tell you a bit about discovery. What does discovery mean? It means understanding on a very basic level why cancer forms, how it develops. We develop more effective methods of preventing cancer from forming. We'd love to put ourselves out of business if we could. That's a challenge. We're developing techniques to detect cancer as early as possible. In general, the earlier you detect the cancer, the more likely it is you can make it go away and never come back. We'd like to develop ways to predict how a cancer might behave to be able to help patients. What's your future going to look like? We spend a lot of time and energy developing more effective and less toxic therapies. Sometimes those are medicines, sometimes those are surgeries, operations, radiation therapies, et cetera, et cetera. And we're also looking to develop methods to connect more people with high quality care. We're fortunate to live here in the Baltimore, DC area where there's a lot going on in the medical space. Patients who live 3 and 4 hours from us are not quite as fortunate. We're really trying to help everybody out there access high quality care. How does that work from a laboratory to a clinic standpoint? We have a lot of translation that goes back and forth, and we'll tell you about that in a little bit. What we discover in clinic, we apply to what we're learning in the laboratory and vice versa. Some of the discoveries that have been made at Hopkins are now being used in clinic to help patients fight cancer. What's happened in the last 20 years based on some of the research that we have done here at Hopkins? Well, a lot has been developed. Back in 2005, 20 years ago, the list of medications we were using to treat patients with melanoma was very, very short. There it is on the left. There really were only 3 agents we were using. In 2025, that list is much, much longer. So lots and lots of research has gone into improving the care of patients with melanoma and non-melanoma skin cancers. What does that mean in terms of outcomes? Great question. Glad you asked. Here's what that means. In 2005, the likelihood that somebody was going to be around 5 years after being diagnosed with metastatic melanoma was about 10%. That same statistic in 2025 has increased 5-fold. That likelihood is now about 50%. So is that great? It sure is. Do we have a lot of work yet to do? We sure do. Lastly, we want to teach the next generation. So we want to inspire and train and mentor outstanding, bright, engaging future leaders that are going to help take the baton and continue to do the research and patient care that I was talking about. That includes basic laboratory science. That includes animal models to understand how disease works. That includes clinical trials that are developing cutting-edge therapies for patients to provide excellent patient care. So that's what we're up to. There's the big group of us from a few years ago, all looking very proud of the accomplishments we've made. So I'm delighted that you're going to join us today. We have a lot of interesting things to talk to you about. Before we get going with our first speaker, I want to bring up Ann Garst from AIM at Melanoma, who has a few housekeeping notes.
Good morning, everyone. It's just so wonderful to be filled in a room with people that care passionately about melanoma and the people that are going through a melanoma treatment. As Dr. Lipsum said, my name is Ann Garst Taylor, and I'm with AIM at Melanoma, and I'm going to get to tell you a little bit more about our advocacy organization later on, but I have 2 quick pieces of housekeeping for you. The first is to say thank you to Dr. Lipsum and everyone with Harvard, excuse me, I apologize, with Johns Hopkins Medicine and all of our wonderful panelists today that we know are going to bring us their collective wisdom. We understand that there will be questions for our panelists today. And so here's how we're going to handle that. If you are joining us here in the room, then what we're going to do is we're going to take those questions directly from you. If you look inside the patient packet that we gave you, there are note cards inside. I hope that you have a pen. If you do not, we'll be happy to get one for you. And then during the course of the day, I have volunteers here. We'll collect those from you and we'll get them to Dr. Lipsum. And so he can divide them among the panelists for our Q&A session that we will have at the end of our symposium. If you are joining us via live stream, we want to welcome everyone that's joining us from Zoom and Facebook and YouTube. There's 150 people joining from all across the world today. We want to thank you for joining us, and we know you'll have questions too. So what you can do is, if you're joining us via Zoom, if you'll look at the bottom of your screen, you'll see a tab that says Q&A. That's where your question goes. And if you're joining us via YouTube or Facebook, then just put your question into the comment section and we'll transfer it over so that we can get it to our panelists. And so with that, I want to thank you again. I want to thank Dr. Lipsum again and turn it back over to him.
All right, thank you, Ann. So let's kick things off. I'd like to introduce Dr. Gerstenblith, who's the first speaker today. Dr. Gerstenblith is in the Department of Dermatology, and we'll talk about surface surveillance, detecting and defeating skin cancer early.
Thank you. Thank you, Evan. All right. I need to see my slides, so I think I'm going to stand here. Good morning, everybody. Thank you for your attention. So as Dr. Lipson mentioned, I am a dermatologist and I have a focus clinically on melanoma. So I'm taking care of patients with melanoma and also people who are at high risk for melanoma. So we'll talk about that today. So in order to sort of, do my job as a dermatologist, it's really important to understand where melanoma comes from, who gets melanoma, what are the subtypes of melanoma that occur, how do we diagnose melanoma, and how do we follow our patients with melanoma from the dermatology angle. So first and foremost, what is melanoma? Melanoma is a tumor of melanocytes. It is a malignant tumor of melanocytes. And melanocytes are the cells. Is there a pointer on here? Okay, so melanocytes are seen on the left on the normal skin panel. They are the brown round cells. They are located just above the basement membrane of the skin. This is a cross section of the skin where you can see the top layer, epidermis, the basement membrane, and the dermis, and the fat underneath. And they sit pretty much individually, and they have connections to the nearby skin cells that are called keratinocytes. And they actually kind of reach up and above the keratinocytes and protect them, little umbrellas over their nuclei to protect from UV damage. Now, if they group together in a ball, but they are behaving normally, that is a mole. Okay, so that's benign. But if they group together like the middle panel and they're larger with atypical nuclei, and that is melanoma. So that's a malignant grouping of melanocytes. If they stay above the basement membrane, that's what we call melanoma in situ. If they start invading below the basement membrane, that's what we call invasive melanoma. So this is just giving us some framework. So why do we care about melanoma? All of us here care about melanoma a lot, but why do we care? We care because it is the most common, potentially lethal form of skin cancer that there is. And it is one of the leading cancers that results in average years of life lost because it can affect young people. So in 2017, it was the 13th out of 45 cancers responsible for years of life lost. And as Dr. Lipson mentioned, when we have sort of distant disease, if you can see stage 4, that those numbers have increased. This is based on 2014 to 2020 data, but the stage 4 disease has a 35% 5-year relative survival rate. But if you look at local stages 1 and 2 that are highlighted in yellow, we see a 99% survival rate, okay? So our goal as dermatologists is to not actually have our patients have to see the medical oncologist. No offense to our medical oncology colleagues, but we want to get patients who have early stage disease that can be cured with surgery. So as dermatologists, we need to find who is at increased risk. Who are these patients who are at increased risk so that we can diagnose melanoma when it is early and very easily curable. So to do that, to find out who is at risk for melanoma, we have to go to epidemiology and say, okay, let's look at the incidence of melanoma. Who's getting melanoma? When are they getting it? And then we can look at risk factors. So if we start looking at sort of incidence of melanoma in the US, a lot of our data come from large database studies, including the National Cancer Institute's Surveillance Epidemiology and End Results Study, which is called SEER, and also the American Cancer Society. So we look and we see that melanoma has actually been increasing in incidence over the last many years. It was sort of stabilizing, but it looks like it's actually still continuing to rise. So in 2025, melanoma is the 5th most common cancer in men and women. There's about 105,000 estimated new cases of melanoma in the US for this year, more in men than women, with about 8,400 estimated deaths, more in men than women as well. And interestingly, the incidence of melanoma varies based on age and sex. And this curve has played out for the last several years. You can see on the left column is the incidence rate per 100,000, and the x-axis is the age at diagnosis. These are 2 different time groups, so 2003 to 2005 and 2013 to 2015. And this is among Hispanic and non-Hispanic whites in this year database. And what we see is something interesting happening between ages 40 and 50, where before age 45, melanoma is more common in young women. And then after age 45, it's more common in older men. Okay, so this gives us a sense of sort of who's getting melanoma and when are they getting it. Other age differences that we see when we look at melanoma epidemiology is that when it comes to who has sentinel lymph nodes that are positive, more young people than old people tend to have positive sentinel lymph nodes. When it comes to survival, more young people have better survival than older people. For sex differences, we can see that in terms of the location on which melanoma arises. So men tend to have melanoma more commonly on the trunk or the head and neck, and women, the most common location is the leg. We also see more adverse features of melanoma in men compared to women. So more of the melanomas are ulcerated in men, and the thickness tends to be greater in men. We also know that the incidence of melanoma varies greatly by race and ethnicity. And this is another from data from the SEER program, looking at incidence rate again on the y-axis. This is now looking at year of diagnosis. And the yellow is Caucasians. The black line is all races combined. But if you look at the green and purple line, that's Asian Pacific Islanders and Alaska Natives. And then the red and the blue on the bottom are Blacks and Hispanic patients. And you can see that Caucasians have much higher incidence rate than other races. And this has been from 1999 till 2014. It's still the case. So this also helps us to understand who's getting melanoma. And we know that, we see that the melanoma incidence, it's not just, one factor at a time, but that really all these factors sort of interact with each other. So for example, being older and male can lead to worse outcomes. So there's interactions between these factors. We can also use epidemiology to help us identify what the risk factors are for melanoma. So we can tease apart melanoma risk factors, and it can help us identify who needs to see us. And we know that these factors, so there's genetic and environmental risk factors, they work individually as well as in combination to contribute to melanoma development. So if we look at family history on the top in yellow, we know that people who have a first-degree family member with melanoma themselves will have an increased risk for melanoma. If we look to the left side in green, pigmentation traits, we know that patients who have fair skin, light-colored hair, red hair, easy freckling, poor tanning ability, sun sensitivity, those patients have an increased risk for melanoma. If you look to the right, people who have just an increased number of benign appearing moles have an increased risk for melanoma, and those who have what we call dysplastic or atypical moles also have an increased risk for melanoma. On the bottom in red, we see the only known environmental risk factor that we currently know of for melanoma, which is exposure to ultraviolet radiation. That can be in the form of sun exposure or artificial tanning. So if you're wondering, well, how much do each of these factors contribute to melanoma development? These are some sort of numbers as to how each of these can increase risk. And I just want to point out, if you look at the mole or nevi category, how strong that risk factor increase is. So for people who have more than 5 atypical moles or dysplastic moles, they have a 10-fold increased risk for melanoma. That's pretty high. And same for people who have a lot of moles. So having over 100 moles, there's a 6-fold increased risk for melanoma. And that's a lot higher than the other categories, if you notice that. And one other comment is that, you know, these factors sort of interact together. So people in the same family tend to also have similar pigmentation traits and travel together. So they might have the same sun exposure when they all go to their sunny locations in the summer. So these are also kind of interacting together. One other risk factor for melanoma is immunosuppression. So these are patients who most commonly are solid organ transplant recipients and are receiving immunosuppression for their organ transplant, or patients with chronic lymphocytic leukemia. They also can have an increased risk for melanoma. So we don't want to forget about that as well. I'll talk briefly about family history. I think a colleague is talking more about genetics later. But in terms of sort of, you know, patients wondering if they have a genetic susceptibility to melanoma in families. So sorry, back up. Only about 10% of melanoma that occurs is within sort of a familial setting. So most people with melanoma, it is considered sporadic, but we are learning a lot more about melanoma susceptibility genes. The most common, frequently identified one being CDKN2A, but hopefully we'll hear a little bit more about these later. Okay, so when we're trying to diagnose melanoma, it's important to know what subtypes of melanoma exist and what they can look like. So we're going to start with the most common subtype, which is superficial spreading. This is, you know, we'll talk later about the ABCDEs of melanoma, but if you guys know about those, that the superficial spreading subtype sort of fits that bill. And again, we'll come back to that. So this is the most common subtype. Nodular is the second most common subtype. These are often very fast growing. They are often bleeding, as you can see with this, and sometimes the surface may be eroded or moist. That's pretty common. These can be very, very fast growing. Lentigo maligna or lentigo maligna melanoma occurs most frequently in older individuals on chronic sun-exposed areas, so the face or the back of the hands, or in this gentleman on the left, his upper back, which has a lot of sun damage in the background. Acral lentiginous melanoma can occur on the palms of the hands or the soles of the feet or in the nail units. You can have mucosal melanoma. Now this is, you know, much rarer than the other types, but in the oral cavity, anorectal area, or vulvar area. Desmoplastic melanoma is a subtype that often can look like a scar. These can be pretty deep. And then there's amelanotic melanoma, and I like to use this to quiz my residents as to which one they thought was the concerning lesion, and it's actually the red one, not the dark brown one. That was an amelanotic melanoma. So these are pink or red melanomas. Okay, so how we make our diagnosis, this ties into how we're going to recognize melanoma early, is we use clinical exam, of course, but we also use dermatoscopy or dermoscopy, total body photographs, and biopsy. So everybody's probably heard of the ABCDEs, but to go over these, this is a helpful tool to teach patients. And, you know, it's probably something we do automatically as dermatologists, but the column on the left shows sort of benign features of benign moles, whereas on the right, these are features of melanoma. So we talk about so a normal mole should be symmetric, one half matches the other half. If you have an asymmetric pigmented lesion, that could represent melanoma. B is for border. We expect borders to be even, to be able to tell where the mole ends and the normal skin begins. In melanoma, you might have jagged or irregular borders. C, color. There's two aspects of color that I teach patients about. The first is Most moles will normally be one shade of a color. Melanoma might have multiple shades. So if you see a multicolored pigmented lesion, red, pink, light brown, dark brown, that can raise your suspicion. The second aspect of color is that if somebody has mostly medium brown moles and then there's a very, very dark black mole or pigmented lesion, that stands out as being sort of different from their other ones, and that may be an indicator of melanoma. D stands for diameter. That's the kind of the least important. We know there are normal moles that can be bigger than that, and melanoma can be smaller than sort of the size of a pencil eraser, which is what we teach people. But so that's not the most important criteria. E, however, then next is the most important criteria. So this is evolution. So this is something that is new or changing. And so if we can, really try and figure out what's new or changing of patients' pigmented lesions, we will be ahead of the game in terms of finding melanoma early. And this is another thing we utilize, a tool we utilize and teach patients about, which is basically looking for the ugly duckling. So if there is something that stands out as looking different than their moles, especially for patients who have a lot of moles, and they may have a lot of atypical moles, and we can't take everything off because we're going to leave them with, tons of scars. So we say, okay, well, this one really stands out and looks different from your others. So that's kind of the ugly duckling sign. Back to, okay, so another tool we use, is dermoscopy. And this is a handheld, non-invasive tool. It's a magnifying lens with a polarized light, and we look at individual pigmented lesions with it. And it can help us see pigment networks and structures such as blood vessels that otherwise are not visible to the naked eye. And in studies, this has been shown to increase the diagnostic accuracy for melanoma compared to visual exam alone. So what we are looking at, these are some images. On the left is sort of just a schematic for how we teach our dermatology residents what to be looking for in terms of normal patterns. The middle column are actually benign lesions that fit those schematic patterns. And on the right column going down are melanomas that have some elements of those normal patterns, but then do not have the full pattern. So this includes sort of a reticular pattern at the top, which is a lace-like. If you look at the one in the middle, that's globular. These are sort of how we describe what we see when we look with a dermatoscope. And we can use this tool to find patterns that we wouldn't otherwise see if we're just looking with our eyes. So dermoscopy is a very important tool. And there's pretty good evidence that people who are doing skin exams should be trained in dermoscopy. So if you're going and you're getting your skin check, you really want a dermatologist who's using a dermatoscope. Now back to the E for evolving. So how can we know if a mole is changing unless we have some type of baseline record of what it looks like? So we use total body photography. There's many different systems to do that, but that basically record sort of a baseline image of patients' pigmented lesions, either all of them or select ones that the dermatologist wants to keep an eye on. We can do clinical photographs, just a regular picture of a mole. We can also photograph the dermoscopic image and follow that over time. But basically, we know that most moles that are benign will be stable throughout people's lives, okay, especially beyond childhood. And so using total body photography, we can monitor changes in pigmented lesions over time, and therefore find melanoma at a really early stage before it even has any obvious features clinically, or even sometimes dermatoscopically as melanoma. But we say, this has changed, let's take it off. There are different approaches for obtaining total body photographs with a range of costs. And as our iPhones and smartphones are getting better, I often will use the patient's phone and take pictures and hide them in their hidden folder, so they can access them, but they're not sort of, going to show their friends when they are showing vacation pictures. It does add time to the skin exam. So, that's a downside of kind of dermatologists adopting this, but it really can improve the early detection of melanoma. And especially this is for patients who are at high risk for melanoma. And furthermore, it reduces the removal of otherwise benign lesions. And so we don't, patients will come in and say, can you just take all my moles off? I'm really anxious about them all. And we say, no, we don't want to, leave you all scarred up, but we need a tool to be able to find the needle in the haystack, to find the one that's changing. So if we look at an example of using total body photography, we see a picture from August 2023 that already has an arrow on it. So we're already monitoring it, whether it was starting to change a little bit at that time, and then, definitely changed by September 2025. And it was a very, very early evolving melanoma in situ. So fortunately, fully curable with surgery. In terms of actually diagnosing melanoma, so those are tools to identify melanoma, but really the biopsy is the gold standard. We need to do a biopsy. There's no substitute for removing the lesion and having it evaluated by pathology. And Dr. Lang will talk later about what goes into that pathology report. There are some modalities that are being evaluated and studied that may help us to identify melanoma in the future, some of which may be non-invasive. So tape stripping, you can take a little bit of the mole with a special tape that can look at gene expression patterns. That may be something that we use regularly in clinic in the future for sort of ambiguous, suspicious pigmented lesions. Confocal microscopy actually looks even deeper than dermoscopy at structures and may be helpful, although currently the confocal microscopes are huge, so it's a little bit cumbersome for clinic. Optical coherence tomography and electrical impedance spectroscopy use sort of surface changes and light and spectral analysis to try and identify benign versus malignant lesions. And then what's really exciting is sort of what's coming with artificial intelligence modalities to use non-invasive techniques to recognize benign versus malignant lesions. And if we can get their accuracy as good as we are or better, I joke with my patients, I'll be very happy to just push the button on a computer one day and let the computer find their melanomas. They still will need somebody to push a button, right? Hopefully. So I won't be out of a job completely, but I welcome a computer doing it better than I can do it, if that's possible. So these are just some recent headlines on sort of these AI skin cancer detection systems. There was one actually approved by the FDA recently that was for primary care doctors. So that's another sort of piece of this is not everybody has access to a dermatologist. So if we can actually have a system where people who are in locations where they can't see a dermatologist easily could get a triage of sort of benign versus malignant of a lesion, that can help us sort of, give care to a broader patient population. So in follow-up, anybody who's had melanoma, we're going to be wondering if they have any new or changing lesions they've noticed. We're going to work up any systemic complaints they may have to just make sure that the melanoma they had hasn't spread anywhere. We do usually every 3 to 6 month full skin exams for patients in the first few years, followed by every 6 months till year 5, and then at least yearly. Sometimes patients who are covered with moles sort of stay at the every 6 month for the rest of their life. We use dermoscopy, total body photography for patients with an increased number of pigmented lesions, always do lymph node exam. And then we're looking at where the melanoma has been removed for evidence of recurrence. And sometimes the recurrence is obvious, like this gentleman on the left, he sort of barely has a resected melanoma from the top of his scalp, and just you can see the black all around and extending onto the scalp. That's not subtle. Whereas the patient on the right, it's a lot more subtle. So you can see the melanoma scar on the shoulder on the right side of the picture, and then 2 very small bluish brown papules that showed up, and that was melanoma recurrence as well. So part of our exam is also monitoring for melanoma recurrence, which tends to go to the skin. We do a lot of education of our patients. So we teach patients that they're at risk for a subsequent, which is sort of a second separate melanoma, as well as non-melanoma skin cancers, such as basal cell carcinoma and squamous squamous cell carcinoma. We review the ABCDEs, what melanoma can look like, what non-melanoma skin cancers can look like. We teach patients how to do self-skin exams, how to use their total body photography. So if I take photographs, I actually want patients to have access to those photographs. I don't want to keep them locked in our clinic. And if they see a spot, I say, get out the pictures, see if it's changed, see if it's different. And if it's different, you should be sending us a message and we'll get you into clinic. We want our patients to encourage their first degree relatives to get skin exams, encourage sun protective behaviors. And in individuals where there is a family history of melanoma, to consider genetic testing for melanoma susceptibility genes. And for our perspective in dermatology, when somebody's already had melanoma, we're going to be following them regardless. So I tell my patients, you having a melanoma susceptibility gene is not going to change what I do for you and how I care for you. But some of these genes increase the risk for other types of cancer. And that's where their clinical care may change. So they may open up the opportunity for them to have other cancer screenings that they wouldn't otherwise have if they do test positive for one of those genes. In terms of prevention, as of now, we don't really have great prevention other than sun protection. So protecting from the most common environmental risk factor. So not going tanning, using sun protective clothing, broad spectrum sunscreen, especially protecting the skin from the sun during peak sun hours. And I will say I have started really educating my patients about vitamin D as well. We are intentionally keeping patients out of the sun, which the sun is a natural form of our getting vitamin D for our bodies, which we know is important for bone health and possibly prevention of other cancers. And interestingly, there have been a lot of mixed studies on vitamin D, but there are some studies that do suggest that a low vitamin D may be associated with an increased melanoma risk or also increase worse prognosis in people who have melanoma. So I am telling my patients, look, I want you out of the sun, but get your vitamin D level checked. And if it's low, talk to your primary doctor about whether you need to supplement it. And then in terms of sort of the risk for another separate melanoma that does exist, that risk is highest in the first 5 years after their first melanoma is diagnosed. And that risk stays increased over 20 years from when their first melanoma was diagnosed. So I basically tell my patients, I'm your doctor for life. You're going to be coming to get skin checks forever because you can always have a second melanoma. And that's not the first melanoma spreading. That is a second separate melanoma. So think of questions, write them down, and I'm happy to answer them later. And thank you for your attention.
Thank you. Thank you, Dr. Gerstenblythe. All right, next up on the agenda, I'd like to introduce Dr. Julie Lang, one of our surgical oncology colleagues. Dr. Lang is going to talk about the surgeon's role in melanoma care. Dr. Lang.
Thank you. Hello, happy to speak with you today. Can we bring up the first slide? Does this include a forward button? All right then. So we're going to be talking about surgeons and how we think about melanoma and what we do with it. And this is going to be focused mainly on patients with early melanoma, stages 0, 1, and 2. What? Okay. Thank you. So this is focused mainly on patients with early melanoma. So is it possible to get rid of that? There we go. So we're going to be talking about surgery for the primary site. That's a big part of what we do. Regional nodal surgery has been a part of surgical melanoma care for a very long time. The way we practice that has changed. Surgeons will also be involved in melanoma care for resection of distant disease. I'm not really talking about that too much in this case, but it does come up from time to time. So melanoma has always been a surgical disease, and there was a time in history when that was really the only thing that medicine had to offer. If someone had melanoma, it would be surgically removed. There was a time during the last century when everybody had a big lymph node dissection of the regional node basin. And while melanoma is still partly a surgical disease today, we fortunately have a lot of other ways to treat melanoma. So over the past decades, the main changes are that we use smaller resection margins than were used a long time ago, which is great. And we have, in general, less lymph node surgery. There's still a lot of lymph node surgery involved, and we'll talk about that. But I do think we're going to see ongoing changes with newer insights into cancer biology and staging, and with new medical therapy. Surgical changes need to happen along with that. So when we take care of melanoma patients, the primary site is mainly for local control, that is getting rid of everything so that it doesn't come back at or near that area in the future. And operations on the regional node basin are partly for staging information, and that's for the last few decades, that's been mainly the sentinel node biopsy. And also for regional control for patients who have disease in the regional nodes. There are some patients who might require a lymph node dissection for regional control. Not everybody today. So we'll talk about pathology. So once somebody has been to the dermatologist and they've had their biopsy, when I see a patient, they usually come with a pathology report. And there's a lot on that report, and that what's on there has changed over the years. So at the top of this list, I put the 3 most important things. So the single most important thing here is the thickness in millimeters. It's also called the Breslow thickness. It's measured with a little ocular micrometer. Second most important thing is histologic ulceration, which means loss of the outer surface over the top of the melanoma. Ulceration is a poor prognostic factor, and it is part of the current staging system, so that is always on the report. The third thing that we pay most attention to is the mitotic rate. Today it's reported as the number of figures per millimeter squared, also measured under the microscope. Those 3 things are the 3 things that we use the most for most patient presentations. The others are important, and they may take on certain importance in particular patients. I'll mention just in passing Clark's level. Many people have heard of the Clark's levels. They're no longer routinely reported, although you will occasionally see them on a pathology report. That was a system of describing what layer of the dermis was invaded by the melanoma. With memory of Wally Clark, we no longer report that, but we remember it. The histologic type, as Dr. Gerstenblith was talking about, is important to us. Other features like regression, lymphovascular invasion, satellites, perineural invasion, also important. But it's really, for the average patient, it's the top 3 things that we're really paying attention to. So for every cancer, there is a staging system. And I think every staging system that I've ever worked with has been flawed. And that is true for the melanoma staging system as well. So the primary tumor is the T stage. And there's a lot on here, but the main thing to notice is that it is divided mainly by thickness. So if the tumor is confined to the epidermis, or the outer layer, it is a melanoma in situ, or a stage 0 melanoma. If it is 1 millimeter or less in thickness, it is in the T1 group. And now we'll see that the T1 through 4 are subdivided by whether or not there is ulceration. Ulceration bumps people up in severity. The T2s are between 1 and 2 millimeters, T3s 2 to 4 millimeters, and T4s above 4 millimeters. Regional nodes, well, here's where it starts getting kind of messy. So the regional node system is a bit complicated. The main thing to know here is that the sense of severity in terms of the regional nodes has to do with how many lymph nodes are involved and what the volume of disease is. Those are the main ideas for how we think about how does the node status contribute to our understanding of severity of disease. You'll notice over towards the right, it mentions the presence of in-transit satellites and/or microsatellite metastases. I'll talk about those in a moment. Those are findings that are high-risk findings with a similar prognostic implication to having a positive node. What are they? So they are defined this way. So we know that melanoma often spreads through the lymphatic system. And if there are little tumor deposits that are separate from the primary tumor, but within 2 centimeters, those are satellite lesions. If they're appreciated only microscopically, they are microsatellites. Tumor deposits in the soft tissue that live more than 2 centimeters away from the primary tumor, but before the regional node basin, are called in-transit lesions. So those are additionally high-risk findings and often have a prognostic implication similar to having positive nodes. So pathologic stage groupings. So the easiest part of this is the top part. Stage 1 and 2 has to do with how thick the tumor is and the fact that the nodes are negative. Things start getting complicated once we get into stage 3. There's a lot of different ways that patients can end up being stage 3, and I think that is the part of the staging system that requires a lot of revision. So this was the way that the stage 3 melanoma patients were presented from the most recent published staging system. And you can see that the committee left themselves a lot of room for improvement. So you can see on the left side here that the stage 3 patients have now been divided into 4 different groups of widely varying prognoses. And in fact, if you look at the top 2 lines, the stage 3A and 3Bs, some of those patients actually have a better prognosis than some patients with stage 2 disease. And if you look at the right side of this page, it's a very confusing jumble of which box people fit into. I think this needs to be revised, and we probably really need some molecular findings and biologic findings to help us really better understand what someone's prognosis is. But to simplify things, at diagnosis, most people have early stage disease. So for invasive melanomas, 80 or 85% of them have stage 1 or 2 disease, meaning they have a primary invasive tumor, but no known regional or distant disease. About 10 or 12% have stage 3 disease, which means regional metastases, but no distant disease. And a very small percent will actually present with distant disease. So at the time we see somebody with a new diagnosis of primary melanoma, there are a number of things in our minds when we're thinking about what we should do or what we should recommend. So one is, are imaging studies or other testing needed? And how much tissue should be excised at the primary site? How big is the wide excision supposed to be? And what are we doing with the regional nodes? Do we need to do anything with the regional nodes at all? And for what purpose? Sometimes we operate on the regional nodes for staging, that is to get prognostic information, or for treatment to control disease at that site. So first of all, who needs baseline imaging? So for these patients presenting with a primary melanoma, stages 0, 1, and 2, most of them do not need baseline imaging. The chance that we would find any actual disease on cross-sectional imaging of the body at that point is extremely low. However, imaging can and should be considered for patients if there are concerning symptoms or clinical findings, like if we examine somebody and find a suspicious feeling lymph node, that's a reason to do some more imaging. Or if somebody presents with a very high-risk primary tumor, like a thick tumor with ulceration, if we think that that's going to be valuable for decision-making for that patient. If a patient presents to us with stage 3 disease, I think all of those folks really should have baseline cross-sectional imaging. Most of the time we don't find anything elsewhere, but I think it's important to have that at the very least as a baseline. So the wide excision. So every primary melanoma needs a wide local excision. And the purpose of that is for local control. That ages ago, every primary tumor used to be excised with a 5-centimeter margin, which led to a lot of skin grafts and in some patients amputations. There were many, many clinical trials in the latter part of the last century and the aughts of this century that compared really big margins with lesser margins. And we now have it pretty well worked out about what margins give appropriate control for different thicknesses of melanoma. So the surgical margins that are recommended have not changed for the last couple of decades. They're pretty well ensconced. These are the currently recommended margins. There's a little bit of wiggle room in some of these. So for in situ melanoma, the standard surgical margin is 5 millimeters. Depending on the location and depending on some other factors, there are some circumstances where one might consider a bigger margin. For patients with thin melanomas, a 1 centimeter margin is definitely enough. There's no reason to do a bigger margin than that. For patients with melanomas that are 2 millimeters or thicker, a 2 centimeter margin is adequate, and there is no reason to do anything larger than that. The only group where there's some ambiguity is the group of patients who have a thickness between 1 and 2 millimeters. The current recommendation is 1 to 2 centimeters. I think it's likely that most of those folks would be fine with a 1 centimeter margin. There's an ongoing multi-center trial to try to better understand that or define that. So the lymph nodes. We spend a lot of time talking about lymph nodes. So these are little structures throughout the body, and the lymphatic system is a circulatory system throughout the body, and we should think about the lymph nodes as functioning as like little filters within that system. So they will filter particles, and it's why lymph nodes may sometimes be enlarged in response to a nearby infection or injury, but they're often the first site of spread for many different kinds of cancer, including melanoma. The sentinel node biopsy has been around for a long time now and is well established as a staging procedure or a prognostic procedure. And the basic idea is that lymphatic flow from the melanoma site will go preferentially through one or a limited number of lymphatic chains. They'll hit one or a small number of lymph nodes as the first site of spread before going on to other lymph nodes. And the sentinel node technique is just a way of finding those initial nodes and selectively removing them. And we know that if the sentinel node is negative, the others are very likely to be negative as well. So we've learned a lot about lymphatic mapping since starting doing the sentinel node. So way back in 1874, Sappi, who was a French anatomist, described the dermal lymphatic flow. He injected mercury into the skin of cadavers and then made these rather elaborate drawings of where the lymphatic circulation of the skin went. And it was all very orderly. That he described that it would seldom cross the midline, and he described a line around the center of someone's torso and called it Sappi's line. And we now know that it's not quite that simple. It's not uncommon to have lymphatic flow from one part of the torso cross the midline and go to the other side. We certainly have had lymphatic flow from the forearm go to the neck. There's a lot of unexpected findings when we do lymphatic mapping. So there have been many studies looking at the value of the sentinel node biopsy, and they are all pretty clear that the sentinel node status has prognostic significance. And for many patients with a newly diagnosed primary melanoma, it gives us the best prognostic information that we have. Some patients may end up being defined as having stage 3 disease if the sentinel node is positive. And the implication of that is that it may lead to the need for staging studies if they haven't had them already. It may lead to the consideration of systemic adjuvant therapy and a plan for closer ongoing follow-up. And this idea is supported by many different studies, which we're really not going into today. But one important thing to note is that the sentinel node use itself is not necessarily associated with better melanoma-specific survival. And that's important to remember in situations where we may be on the fence about whether a sentinel node is appropriate for a given patient. So we know that some features of a patient's presentation that are associated with having a positive sentinel node. Features of the primary tumor include thickness. By far, thickness is the most important feature. Ulceration is important. An elevated mitotic rate is associated with an increased chance of having a positive node, and the finding of lymphovascular invasion also associated with an increased chance. Anatomic location, head and neck primaries more likely to have positive nodes than frontal or extremity primaries, and age is associated with positive node, with younger people being more likely to have a positive node than an older person with the same tumor. And there are a lot of different statistical models that have been published to think about what's the chance that a person might have a positive node. I think they are all flawed in different ways. I don't use them routinely. One that we use occasionally is from the Melanoma Institute of Australia, and I think it occasionally gives relative guidance. I do not use this on a regular basis, but there are a variety of models out there, and in the future, we might end up with better models. So given all this, who should be considered for a sentinel node biopsy? So we consider it for patients with invasive primary melanoma, particularly if they are clinically node negative, that is, we do not feel any enlarged or abnormal feeling nodes, and they either have a primary tumor thickness that's 1 millimeter or more. We will sometimes also consider it for patients with a thin melanoma, particularly if they're towards the high end of the thin range with certain high-risk features like ulceration or an elevated mitotic rate. But there are other considerations. That's not really the whole story. We have to take into account someone's comorbidities, that is, how their health is in general, their age, their life expectancy related to other health problems. We have to take into account the risk of anesthesia for that patient. Sentinel nodes in general will require general anesthesia, whereas some wide excisions could be done under local anesthesia. And for individual patients, that may lead to a change in the decision. And also a realistic patient expectation of benefit. Are we actually going to use the results? If we like when we do a test, we like to think we're going to use the results. And if this is a result we're not going to use, we should think long and hard about why we're doing it at all. So for patients who do have a sentinel node biopsy, they first go to nuclear medicine, and the folks in nuclear medicine do an intradermal injection of a tracer called technetium sulfur colloid. It is a tiny amount of a radioactive substance. There's the injection happening in nuclear medicine. They have a lymphoscintigraphy, which is just a way of getting a broad look at where that tracer goes. Usually we start to see the sentinel node within about 10 minutes after the injection. And then in the operating room, we use a little handheld probe called a gamma probe to help us hear where that tracer went. That technetium is a gamma emitter, and this probe turns that gamma emission into an audible signal so we can help find where that node or nodes are. This is a very old model that's not currently in use. Some surgeons will also use a visible dye. The most common one is isosulfan blue. I seldom use it for melanoma patients, but it is kind of pretty. That's what it looks like if you use the visible blue dye. So if the patient does have positive nodes, most node positive patients have a microscopically positive node, either a few millimeters or even less than that, sometimes very small amounts, sometimes found only on the immunohistochemistry. And there's also a lot of discussion and a little bit of uncertainty about what size tumor deposit is really clinically meaningful. Is it 1 millimeter? Is it 0.3 millimeters? That becomes a decision that our medical oncologist would think about. So it used to be that we thought that if somebody had a positive node, we should go back and take out the rest of the nodes because we thought there was a good chance some of those other nodes might be positive. And from older studies, we used to think that there was about a 20% chance that there would be other nodes in that basin when we went back and did our dissection. So we now know that we really probably shouldn't be doing that in this day and age for most patients. So there were 2 large trials of node basin dissection, as was always done, versus careful surveillance. And they both showed the same thing, that immediate completion dissection did not improve melanoma-specific survival. It did somewhat improve regional disease control, and it provided in some patients some extra prognostic information if they did find additional positive nodes. But because it did not improve melanoma-specific survival, today we really should not be doing completion dissections for most patients. There may be exceptions to that, but there aren't very many of them. So we know that those patients, if they do have a relapse into that node basin, they may need a dissection in the future. And so the type of surveillance that we do, this mimics the type of surveillance that was done in those trials. for year 1 and 2, they get an ultrasound of that regional node basin every 4 months. Then in years 3 to 5, they get an ultrasound every 6 months. During that follow-up time, the chance of in-basin recurrence may vary with a lot of different factors about that patient, but overall it's about 10%. And so we do want to keep a close eye on that basin. Some of those patients may end up needing a lymph node dissection in the future. So I thought we'd end by looking at a few cases. These are fictional cases, and you can tell that because I've given them fictional names and I've totally made up their pathology. These are not real people. So first, we're going to talk about Miss Jane Eyre. So she is a 45-year-old woman, and she's been to her dermatologist and had a biopsy, and they found melanoma in situ of her left arm. This is a stage 0 melanoma. She certainly does not require any preoperative staging studies. Her best management is wide excision alone with a 5 mm measured margin. Once that is done, the chance of recurrence of that should be 0 or incredibly close to 0. She will need to remain in skin screening indefinitely, as Dr. Gerstenblith told us. Next, we've met Miss Elizabeth Bennett, and she's a 22-year-old woman with an invasive melanoma at the right calf. So this melanoma pathology report says it is 1.2 millimeters in thickness. It is non-ulcerated with a mitotic rate of 2. So it's a T2 primary tumor. It has a slightly elevated mitotic rate. So we're a little bit concerned about this melanoma. It's not high enough risk for us to order any imaging evaluation. Primary site here should have a wide local excision with a 1 centimeter margin. Once that is done, her chance of local recurrence really should be 1% or less. It's not 0, but it's very low. And she also does qualify for a sentinel node biopsy, and that will help us understand whether she is at higher risk of future recurrence or lower risk of future recurrence. And I think it is an important part of her treatment, her management for a healthy young person with this finding. Next, we meet Mr. Twist. So poor Mr. Twist survived his terrible childhood, and he's now a 25-year-old with invasive melanoma at the right back. And this is a more challenging melanoma. This melanoma is 4.5 millimeters in thickness. It is ulcerated, has a mitotic rate of 10. So this is a pretty serious high-risk melanoma. And by that alone, he really should have some baseline imaging, and that could be either a CT scan or a PET CT, but he needs to have some form of baseline imaging. If we assume that that shows nothing, then his primary site should have a wide local excision with a 2 centimeter margin. I think that's appropriate to give him durable local control. He also would be a candidate for sentinel node biopsy, and with a melanoma of that description, his chance of having a positive node could be around 40 or 50%. So this is indeed a very serious problem. Regardless of the node status, it's important to note that this patient should have an oncology consultation regardless of his node status. Because even with a negative node, the primary tumor here has such high risk features that he could be considered for adjuvant therapy, even if his nodes are negative. And we'll move on to one more patient, Mr. Sancho Panza. So he's now an 80-year-old man with an invasive melanoma at the left shoulder. So his pathology report says it's 1.2 millimeters, it's non-ulcerated, and it has a mitotic rate of 2. And if you've been paying attention, you'll notice this is exactly the same pathology report that Ms. Bennett had. But his situation is quite different. He's an older man. He's on home oxygen for his lung disease. He has congestive heart failure. He's a terrible candidate for anesthesia. He does not require any staging imaging for this presentation. And an appropriate management for him would be for a wide excision alone with a 1 centimeter margin. And we can do this under local anesthesia, so he doesn't need to undergo the risk of general anesthesia. I would recommend against a sentinel node biopsy for this patient. So those are all our fictional patients.
Thank you. All right, next I'd like to introduce Dr. Jessie Tao to talk about genetics. Genetics is complicated. There are genetics of the tumor, and then there's genetics of the human, and they sometimes are the same and they're sometimes not. So, Dr. Tao.
Thank you very much, Dr. Lipson. I am very glad to be giving this talk today. As a caveat, I am a breast medical oncologist, so I primarily clinically focus on breast cancer. However, I direct our cancer center's Johns Hopkins Molecular Tumor Board. And so in that setting, we review cases from across the cancer center for all tumor types and review the next generation sequencing or molecular profiling from all solid tumors. So I'm going to be focusing on discussing somatic versus germline, which is a very important distinction to be making when we're thinking about inherited versus acquired mutations in melanoma. Then discussing some of the germline susceptibility genes and syndromes in skin cancer, but with a focus on melanoma, and then covering a little bit about inherited susceptibility in melanoma and who to test for these germline susceptibility genes. And then discussing some of the somatic mutations that we can see in melanoma, and then followed by take homes. So this is a really important distinction to understand when we're talking about genetic changes in any cancer type, including melanoma. And this is the germline versus somatic. So okay. On the right, we see what are germline DNA changes. What that means is that these are DNA changes that were present at birth, meaning they're present in every cell in the body, including the egg and the sperm, and were passed on from a parent and can be then passed on to children. They increase cancer susceptibility, so they're inherited mutations. And then in contrast, there are somatic DNA changes which were not present at birth and are acquired in a person's lifetime in single cells in the cancer. They can lead to cancer and they cannot be inherited or passed on. So what are some common differences between germline and somatic? I kind of made this table here to make the distinction. So in germline mutations, this is what it asks is, was I born with a gene change that increases my cancer risk? Whereas with somatic means what gene changes are in my cancer right now. The testing is different between the two. So to test for germline mutations, that's typically on a saliva or sometimes on a blood sample, whereas somatic mutation testing occurs on the tumor tissue itself. And now more and more through blood, what's called a liquid biopsy, which is looking at tumor DNA that's shed into the bloodstream that can sometimes be picked up on a blood sample. Germline, the purpose is to find an inherited risk susceptibility, and it can guide further screening for the melanoma or other cancer types, whereas somatic guides treatment choices and clinical trials. Germline, again, may apply to relatives, where somatic usually does not apply to relatives. And with germline testing, that's usually done once, sometime at diagnosis, whereas somatic can be repeated multiple times as the DNA and RNA changes evolve in the course of a patient's cancer treatment. So this is a big table of germline predisposition genes and skin cancer. And we're not going to go over all of this today. Each one of these could be a separate 10-minute talk. But these are some of the syndromes or conditions and their associated genes that are associated with skin cancer. We're going to be focusing on melanoma primarily. As Dr. Topalian mentioned, most melanomas are not inherited. In fact, only 8 to 12% of patients with melanoma have a family history of the disease, but not all of these patients have hereditary melanoma. So for example, you can be part of a family that has a common behavior or a common heavy like sun exposure and a susceptible skin type. So it's not that they have an inherited gene, but rather something else that's making the family more susceptible to melanoma. Within inherited susceptibility genes, there are multiple, and we won't go over all of them, but they're classified into what's called high penetrance versus intermediate penetrance. High penetrance means that if somebody has this inherited gene, then it's likely that they will develop melanoma at some point in their lifetime. Whereas intermediate or low penetrance genes are an inherited gene, but that doesn't increase the likelihood of getting melanoma by much. One of the most common inherited susceptibility genes is this mutation in what's called CDKN2A, which is mutated in around 20 to 40% of high-risk families. CDKN2A, which is shown at the top of this figure here, is a gene that encodes two proteins, P16 Inc4A and P14ARF. And each of these proteins is responsible for regulation of the cell cycle. So P16 Inc4A, when it is mutated, it causes uncontrolled growth and proliferation through the cell cycle. So basically, it allows the cells to divide unchecked. Whereas a P14 ARF controls P53, which is involved in apoptosis or cell death. And so when that's mutated, then the cells don't die. So essentially having a mutation in CDKN4A leads to a dysfunctional protein, which allows the cells to divide and grow abnormally. The penetrance, for individuals who carry a germline CDKN2A mutation varies from, in some studies, as low as 28% to more than 90% by age 80 years of age. So basically, if you have this mutation, it means up to, by age 80, around up to 90% of those individuals will have an experience of melanoma. So who to test for hereditary melanoma? Obviously, speak to your physician, dermatologist, or medical oncologist about this, but in general, there are some guidelines about who to test because, again, the majority of people will not have an inherited gene that predisposes them to melanoma, but there's different criteria depending on whether that person lives in a geographic area with low melanoma incidence or moderate to high melanoma incidence. In the US, we're considered a high melanoma incidence geographic region. Other areas like Australia are also considered that. But in high melanoma incidence, basically, if you have yourself have had melanoma 3 times, 3 primary melanomas, or families with certain clinical features in first or second degree relatives. So family history of melanoma or pancreatic cancer, because that's related to the type of the CDKN2A can also increase the risk of pancreas cancer. But in general, the bottom here I've summarized who to consider for testing. These are people who have been diagnosed with melanoma at an earlier age, have relatives, multiple relatives with melanoma. You yourself have a melanoma, multiple primary melanomas, or certain other cancer types in your family. Now we're going to move on to somatic mutations. So again, these are acquired mutations that happened in the cancer, that are happening in the cancer cells themselves. And again, a long list of potential somatic or acquired mutations in melanoma. We won't be reviewing all of them, but we'll discuss in the next few slides some of the more common somatic mutations that we see. The most common is BRAF mutations. BRAF, which is shown in this, in the right there in the blue in the middle, is a type of kinase in what's called the MAP kinase signaling pathway. It regulates cell growth, survival, and differentiation. And basically, mutations in BRAF lead to abnormal pathway activation, which causes more cell growth and survival. This occurs in about 40 to 50% of cutaneous melanomas, this BRAF mutation. And the most common mutation is a mutation in called BRAF V600E. This is clinically relevant because there are FDA-approved therapies that target BRAF mutations, including the ones that I've listed below. These are called BRAF-MET combination therapies. KIT mutations are also a common, relatively common somatic mutation that occurs in melanoma. KIT, which is that purple Y-shaped structure up there, is a gene that makes a cell surface protein that acts kind of like a growth switch. So when it's mutated, the growth switch turns on and leads to more cell growth and activity. This mutation occurs in about 1 to 3% of all melanomas, but is enriched in certain types of melanoma, such as acromelanoma and mucosal melanoma. Also clinically relevant because there has been some efficacy of a targeted therapy called imatinib or Gleevec against mutations in KIT. And another common mutation is NRAS, which is another receptor tyrosine kinase that is above BRAF. These also activate downstream signaling pathways in MAP kinase and PI3 kinase that lead to abnormal cell cycle dysregulation and dysfunction and abnormal growth and proliferation. This mutation occurs in about 20% of cutaneous melanoma. At the moment, people have tried to target NRAS, but it's been challenging. Dr. Warrior will be talking more about treatment in melanoma and clinical trials, but this is another common mutation that's seen in melanoma. So take-home messages, again, though most skin cancers are not related to an inherited susceptibility gene, you should discuss with your care team that two primary questions: should I or my family be tested for germline or inherited mutations? And if one does have a diagnosis of melanoma, most commonly this is important in metastatic melanoma. Is tumor next generation sequencing appropriate? And how will those results change my treatment or my screening? Yeah.
Thank you, Dr. Tao. Lots of info about a complex topic. All right, next up is Dr. William Scharfman, my colleague and mentor for many years now. Dr. Scharfman is going to discuss therapies for patients with advanced skin cancer. Dr. Scharfman.
Good morning. Thank you all. Here, I want to thank Maura Caden and Kim Palmer and Evan for organizing this event and speak. Why I need to advance something here. Just one moment here. My focus today is going to be on standard FDA-approved therapies for advanced melanoma. These are things that are approved, that are FDA-approved, that the insurance will pay for if one needs them. So whenever I have at least one member of the audience who's new to me, I like to tell this story about a patient. I think it illustrates the power of immune therapy in melanoma and the potential. And case is a 36-year-old woman with widely metastatic melanoma. This goes back to the earlier years of immune therapy. She was very healthy except the metastatic melanoma. She was married. had twin 7-year-old boys, and she taught physics at the Naval Academy. She came to us with metastatic melanoma. At the time, we had the expanded access trial of Lumab and nivolumab, Opdivo Yervoy, which we'll talk about in more detail. She went on that trial. She, at 12 weeks, had obtained a complete remission and had no side effects. The first and last patient had no side effects. And 2 years out, she's in complete remission. And she calls me and says, Dr. Scharfman, you know, I really would like to have a baby, well, little, like to have a baby. And I said, no, that's not a good idea. You just have metastatic melanoma. We don't know what's going to happen. And fortunately, she didn't listen to me. And this is one of the most glorious days in my life, in my clinic, when she brought the little baby in. And baby's fine, mom is fine. And this is our 10-year later Christmas card. Okay. So that's the beauty, the potential of immunotherapy in melanoma. You have a patient that has metastatic melanoma. If we can't prevent the disease, we give them the therapy that doesn't make them sick, and they truly go back to their normal routine. And by the way, I have permission to show these pictures. Okay, now, so if you go back a little bit, in 2010, we only had 4 treatments for metastatic melanoma. We had high-dose IL-2 as an immunotherapy, which did get a few patients into complete remission, but the rest of the therapies did not work very well. And then by 2025, we now have this huge list of therapies for metastatic melanoma or high-risk melanoma that are very effective. And how did we make such a dramatic change? And it's really a lot of work understanding the immune system. And these 2 gentlemen got the Nobel Prize for that work, Dr. Allison for discovering the CTLA-4 molecule and Dr. Hanjo for discovering the PD-1 molecule. And the thing that we knew beforehand was that in the immune system, there is a balancing act. There's things that push the immune system to go after germs and viruses and cancer. And there are other elements that push back on the immune system to not let it go overboard. And those are there for those blockers, those brakes are there for a purpose that we don't want if we didn't have those brakes, then we'd all have autoimmune diseases like lupus or ulcerative colitis. And these 2 found these 2 brakes, the main brakes that have changed everything, the CTLA-4 brake and the PD-1 brake. And they realized if you could turn these brakes off in the immune system would do what it's supposed to do and eradicate cancer. So the two discoveries, the 2 brakes that have really started things off was the CTLA-4 brake and the PD-1, which we also call a brake or a checkpoint is the more common terminology now. And the discovery of the CTLA-4 checkpoint and the treatment of that and attacking that checkpoint has led to only 1 approval in cancer, and that's in melanoma when given in melanoma. And slide, I think it's not too complicated. When you're trying to eradicate cancer, you want the immune system to create a T cell that will attack the cancer. And for the T cell to get activated, the antigen presenting cells in the immune system have a piece of the melanoma that they present to the T cell. 2 molecules have to be activated. And then when that happens, the CTLA-4 molecule shows up and turns off the immune response. And Dr. Allison realized if you made an antibody to that CTLA-4, if you turned off that CTLA-4, turned off that checkpoint or that brake, you could allow the immune system to eradicate cancer. And by the way, if you haven't done it, there's a really great video about Dr. Allison called Dr. James Allison Breakthrough, which showed his persistence in getting this anti-CTLA-4 into the mark. The PD-1 is the other checkpoint that really has led to dramatic changes in immune therapy, and that's discovered by Dr. Hanjo. And that's led not only to approvals in melanoma, but all kinds of other cancers. I think 30 different cancers right now, or 30 different indications. And the PD-1 molecule is also on I wish I had a pointer, but the PD-1 molecule is on the T cell And on the tumor, there's often the PD-L1 molecule. And when they interact, they turn off the T cell. And when the different antibodies, the anti-PD-1s, the nivolumab, pembrolizumab, Keytruda, Opdivo, they interact between this, they get in the way of this interaction between PD-1 and PD-L1 and allow the T cell to be activated and eradicate tumors. And you just heard about gene mutations, so I'm not going to dwell on this too much, but this other discovery was extremely important in the melanoma world. That was that at that time we thought 66% of malignant melanomas had the BRAF mutation. And understanding that led to a lot of work and the discovery of several drugs that target BRAF and mutant BRAF and target MEK. And now the standard of treatment for patients with BRAF mutations is to give them a combination of drugs which target mutant BRAF and target MEK. And every patient who has advanced melanoma or high-risk melanoma should have what we call next-gen sequencing done to determine if they have this mutation. And this is just a pathway which actually you saw before. The MAP kinase pathway, you have the BRAF, you have BRAF and you have MEK next to each other. And when you treat BRAF mutant melanoma, you target BRAF and MEK simultaneously, and that can lead to prolonged remissions in advanced melanoma. Okay, so what I'm going to do is break down treatments by stage. And thank you for Julie Lang, who introduced the staging system to you. It makes my job a little bit easier. But just to review, stage 1 and stage 2 melanoma are melanomas of increasing thickness. And we determine 1 or 2, A, B, C, A, B, or C, if they have ulceration or not. Okay. So to be stage 1, you have to be less than 1 millimeter with no ulceration. Stage 3, very simplified, is lymph node involvement. That goes, as you saw, from A, B, C, or D, A being early microscopic involvement that you would only see under the microscope. And then B, C, D meaning more and more lymph node activity. And then we have stage 4 for metastatic disease. 1A is skin or lymph nodes only, B is lung, C is everything else, and except D means one has brain involvement as well. And we also use the elevated LDH or not elevated LDH as a marker of prognosis. So for the patients who present with stage 1A or B or stage 2A melanoma, so that is up to 2 millimeters without ulceration, with or without ulceration, there is no suggested treatment after their wide excision is done. It should be monitored, but there's no recommended therapy. For the stage 2B and 2C patients, there is a treatment to consider. Stage 2B again means the melanoma is more than 2 millimeters with ulceration or more than 4 millimeters without ulceration. As Dr. Lang said, it's a bit of a confusing system. Stage 2C is melanoma more than 4 millimeters with ulceration. And for those patients, after their wide excision, after they've had a negative sentinel node biopsy, there's an FDA recommendation to consider giving a year of anti-PD-1 therapy, which is either pembrolizumab, Keytruda, or Opdivo, following their surgery. Now, this is an area that a patient population we spend a lot of time talking to about what to do. The problem, not the problem, but the issue is that a lot of these patients are going to be fine if you do nothing as far as adjuvant therapy. So if you take the stage 2B patient, 80% of them will be fine at 3 years, and did I make it correct? I think I made that. Anyway, the majority of patients in this group are going to be fine at 3 years. And if you give the immune therapy, 15% of them are going to have significant side effects that you're going to have to deal with. And that's a big issue. And one of the things we don't know for the stage 2B and 2C patients is maybe they would do just as well if you did not give them therapy right away, but monitor them closely and then gave immune therapy when they relapsed. And that is something we still don't know. It was part of these studies looking at treating these patients. the second part of the studies. We just don't know the results of that right now. So again, the concern is you may give them toxicity that could be very difficult to deal with. So I'm not going to spend a lot of time about toxicity, but whenever you give anti-PD-1 therapy or anti-CTLA-4 therapy, you run the risk of giving significant toxicities. If it's just single agent nivolumab or single agent pembrolizumab, it's a 15% chance. The things we deal with, colitis, skin rash, hepatitis, adrenal insufficiency, hypothyroidism, we're all very used to dealing with them, and we know, and generally get people through them pretty easily. The concern is that even when you just give a single drug, there's a small chance, like a 1% chance, of having some very unpleasant side effect. And we're learning about more and more of them as time goes on, but we worry about myocarditis, where patients go into heart failure. We worry about neurologic things where patients develop Guillain-Barré syndrome. So even when you're giving one drug, you have this very small chance of something really bad and unpleasant happening. And you have to weigh that when you're discussing whether to give immunotherapy to a patient with relatively early disease like stage 2B or 2C. For stage 3 patients, we do recommend additional therapy. And again, stage 3A is microscopic lymph node involvement. And stage 3B, C, and D are increasing amounts of lymph node involvement. It's a little more complicated that there's in transit stuff, matted nodes, but more and more disease. And for those patients after surgery, after a lymph node dissection, a year of nivolumab, a year of pembrolizumab, or a year of targeted therapy, specifically with dabrafenib or trametinib, for the V600E or K patients is recommended as good options. And this is, Dr. Lang said, for the stage 3A patients, they do not need lymph node surgery, but for the stage 3B, C, and D patients, they do need to have a completion node dissection before you go on to adjuvant therapy. And at this point in time, it appears that whether you give immune therapy or you give targeted therapy, the patients do just as well. I am immunotherapy biased. I thought that was not true, and maybe for longer follow-up, it will turn out to be not true. But at this point, it turns out that targeted therapy or immune therapy as adjuvant treatment for the stage 3 patients is just as effective. So it's a good choice. For some patients, a good choice. For patients that have underlying autoimmune disease, it's a very good choice. And for patients who don't want even a 1% chance of having a really bad side effect, then the targeted therapy is a good option. The newer approach to the patients with higher stage 3 disease is neoadjuvant treatment. So the patients who come in with palpable lymph nodes, we know that they do not do as well with surgery followed by adjuvant therapy as the patients with earlier stage 3 disease. So in the NCCN guidelines, there's a couple options. One is to give 3 doses of pembrolizumab or Keytruda before surgery, or to give 2 doses of ipilimumab and nivolumab before surgery. And then they go to surgery, and then after they have their surgery, they have a pathology report. And depending on what the pathology shows, then you may continue adjuvant therapy or may not. If a patient has a complete pathologic remission, you can make a case for not doing any more immune therapy after their surgery is done. And this is not really complicated. This is kind of just an illustration of why this makes sense. It's neoadjuvant therapy treatment before surgery. That is when a patient shows up with a palpable node, that there's a high likelihood that there could be some additional small melanoma spots around the body. By just going in and doing surgery right away, you're not going to address that. So if you give the immune therapy first, you turn on the immune system and attack the melanoma, even the small stuff you can't see that may be there. And it does appear that this neoadjuvant approach, giving immune therapy before surgery, is the way to go for patients who show up with palpable adenopathy. Okay, so then we're stage 4 disease. Again, there's 4A, B, C, and D. And again, A is early, D is farther along with brain involvement. And there are a couple FDA-approved therapies, ipilimumab and nivolumab, then Opdualag, then just giving nivolumab or pembro by itself, then the option of giving targeted therapy. And then also when someone comes in with, metastatic melanoma as a clinical trial, and that's great. There's just not very many clinical trials for initial treatment of melanoma at this time. So, sorry, let me go back. So you have to, the standard for us is that if a patient is healthy, they should get ipi/nivo for their metastatic disease, understanding there's a 50 to 60% chance of toxicity. The Opdualag is a good option, much less toxicity, probably close to as good as ipi/nivo. And for patients that are just really not well, who will not tolerate bad toxicity, giving a single agent therapy is a reasonable thing to do. And then for some patients, if they have the BRAF mutation, starting off with BRAF and MEK-directed therapy is reasonable, particularly if a patient has an underlying autoimmune disease where it's not safe to give immune therapy, giving targeted therapy is a reasonable thing to do. If you really need a very, very quick response, you may want to start off with targeted therapy first and then go to immune therapy. The drugs I use of all the combinations is the BRAF/TOVI and MEK/TOVI seems to be the most active and less toxic of all the combinations. Oops. And one question that comes up in the patient who has a BRAF mutation, do you start off with immune therapy or targeted therapy first? And there's been 2 trials done that have looked at this. And for the patients who have a BRAF mutation who are otherwise fit, no autoimmune disease, it appears if you start off with immune therapy, the patients do better. They live longer, less chance of relapse, less chance of brain metastasis. So if you have a patient who has a BRAF mutation, and you want to know that, but even if they do, generally we can start off with immunotherapy first. And this is the only survival slide I wanted to show, but this is looking at the 10-year follow-up of giving ipi/nivo, Opdivo, Yervoy, and the top line, I guess that's kind of orangish, shows if you got the combination and you had a better chance of being fine at 10 years than if you got just nivolumab by itself, or if you just got ipilimumab, Yervoy by itself. So this remains for me the gold standard when we compare our regimens for initial therapy with metastatic disease. And it's also interesting that for patients who have small brain metastasis, this ipi/nivo combination works really well, over a 50% response rate and many long-term remissions. So just quickly, if the ipi/nivo, and I stole this from the NCCN guidelines because they do a better job than I can do. And I just want to point out a couple things that, what do you do if the ipi/nivo doesn't work? Well, you can switch to Opdualag. Whatever you haven't tried, you could try. And at this point, for the patients who fail nivolumab or Keytruda-based therapy, we suggest doing TIL therapy if you're fit, because this has the best response rate in the patients who don't respond to our standard therapies. I'll come back to that in a second. I just wanted to point out on the bottom that it's very important that you get this next-gen sequencing done, this mutation testing done, because sometimes you get lucky and find that a patient has a mutation you can target. And doesn't happen very often, but you have no other options. You want to make sure you've had good next-gen sequencing and make sure there's no target that this melanoma might have. It's in the low percentage that you're going to find a target, but they are there, and it's important that you have a thorough mutation analysis for all the melanoma patients with advanced disease. So this is an illustration of TIL therapy. It's complicated, or I shouldn't say complicated, it's involved. They just have to have a tumor. They can be removed surgically to send to the lab to make the TIL cells, the tumor-infiltrating lymphocytes. Patients come in, get their intense chemotherapy to knock out their bone marrow, and they're given an infusion of the TIL, tumor-infiltrating lymphocytes. And then they get a drug called IL-2 for 6 doses afterward, and then they recover from that. And it's a very intense therapy. It's not meant for everybody, and patients have to be fit to get interleukin-2. But it offers over a 30% chance of responding to treatment, and responding in a meaningful way, meaning a complete remission that can be long-lasting in patients who failed to respond to anti-PD-1 or anti-CTLA-4. And I'm going to just make this quick. So I just want to highlight, we have a trial which is opening, I think, very soon, looking at a new inhibitor of a checkpoint, which is, well, inhibitor of the checkpoint, we know PD-1, but an agonist of another agonist molecule that turns on the T cell called 4-1BB. It's kind of a unique molecule. It's designed for patients who have failed to respond to who responded but did not respond, failed, then they lost their response to immunotherapy. We hope this trial will be up in the next few days. It's a very interesting molecule. I think it has a lot of potential. If anyone's interested, you can reach out to us and we'll have the patient evaluated. Thank you very much.
Great. Well, thank you for that excellent talk. I recall, gosh, almost 20 years ago now, when I got onto the oncology ward and Dr. Scharfman was there as the senior physician. And I remember seeing these patients that were getting immune therapy back then and remembering how potentially powerful those drugs were in helping the patient's immune system see these cancers and knock them out. In fact, I still have one of those patients in my clinic whose cancer appears to be gone 20 years later. So the immune system is a tremendously powerful thing. And when it zaps cancer, that's exactly what we ask it to do. But sometimes it does not. Sometimes it misses the mark and it hits something else in the body. So our senior nurse practitioner, Megan Schallenberger, is going to talk to you today about what happens when the immune system attacks a part of the body we would rather it not.
Everyone. Okay. All right. Hey, everyone. I'm Megan. I'm excited to talk to you about immunotherapy toxicities today. So Dr. Scharfman went into this briefly in his talk. He's discussed also the success of immunotherapy, but we also need to discuss some of the side effects that come along with the successes. So just briefly to go into what are immune checkpoint inhibitors. Immune checkpoints are a normal part of your immune system that act as a brake, preventing an immune response against healthy cells. So, you know, in somebody out there without cancer, an immune checkpoint failure could be an autoimmune disease like rheumatoid arthritis, psoriasis. There's a whole laundry list of them out there. The same immune checkpoints prevent your immune system from attacking the cancer. So we don't have a pointer here, but you can see that there's a tumor cell, and the tumor cell holds up, in this case, a flag called PD-L1 that shakes hands with the T cell. And that prevents kind of the immune system from saying, hey, you are the bad guy, I'm gonna not attack you. So these immune checkpoint inhibitors go in and actually block that handshake from occurring and hopefully allow the immune system to attack and kill the tumor cells. So basically, the immune checkpoint inhibitors are drugs designed to release the brakes, allowing your own immune system to destroy cancer cells. So as discussed, sometimes we miss the mark. So what can happen when you release the brakes of your immune system? So we need our immune system to go everywhere in our body because we need it to fight infections. We also want the immune checkpoint inhibitors to work everywhere in our body because we want it to attack the melanoma or cancer wherever it may be, whether it's the brain and the skin, the bones, etc. Meaning that when we release the brakes on your immune system can go everywhere and unfortunately can start attacking an organ we don't want it to attack. So I like this graphic because when patients are coming in saying that they have a new symptom, or we are seeing a new abnormal lab value, or we are finding an abnormal exam finding, this photo is going through my head about where the immune system goes and where all the itises or inflammation can occur that can then lead to damage to the organ. So there are a few common places. Your skin's your biggest organ. So dermatitis or inflammation of the skin resulting in rashes or other skin conditions is one of the common things we see. Also colitis, which would be inflammation of the bowel resulting in diarrhea, bloody stools. Sometimes it can impact the upper bowel, so nausea. The thyroid is particularly susceptible to immune system inflammatory response. And so we monitor your thyroid very closely. And then there are some really rare side effects that we see. Luckily, the organs that seem to be impacted the least are the most imperative organs, like your heart. So inflammation of the heart is a very serious side effect. Luckily, it's not very common. And then there's side effects that I have seen maybe once in my 10 years of being here that are very rare. So when I'm seeing people on immune checkpoint inhibitors, every single time one of your oncology team is seeing you before the treatment, this is kind of what's going through our mind when we're thinking about what are the side effects that may be happening. So how do we recognize the side effect? One is we ask you to report any new side effects or symptoms to your care team. We don't know something's happening unless you tell us it is. Routine labs. So anytime somebody's getting an immune checkpoint inhibitor, they're getting routine blood counts, kidney, liver, and thyroid tests. If you have a symptom that we think is not being picked up on the routine labs, but you're coming in here saying I have joint pain, we might order additional tests to evaluate specific symptoms. And then you're getting exams prior to each treatment. We're monitoring your blood pressure, listening to your lungs, often looking at your skin. So then, say we think you have a side effect from immunotherapy. Your immune system has now attacked an organ we don't want it to attack. In our minds, we're thinking, is this life-threatening or is this not life-threatening? Or could it be life-threatening quickly? So not life-threatening would be a low risk, but can negatively impact your quality of life. So it could be an itchy rash. It's not everywhere, but you're very itchy. The itching's keeping you up at night. That's not going to be fatal. It's not going to put you in the hospital, but it sure is impacting your sleep. Arthritis is another one that we see where people have some joint pains. It can make kind of moving around a little more difficult, but it's not going to, imminently impact your become fatal often. And it typically allows us to continue immunotherapy with supportive care. Topical steroids for the itching, some antihistamines. And then we go to potentially life-threatening. And some of these, like dermatitis, so skin toxicities, can kind of go in between both. So somebody with a little bit of itching, it's annoying, versus somebody with a rash all over their body can become life-threatening. So we're really thinking about where are we on this spectrum. Life-threatening, is we think you have inflammation in your lungs and your oxygen levels are down. And this requires really early recognition, patient communication, and timely evaluation. We're often holding immunotherapy and administering immunosuppression, meaning we need to pull back on the immune system. We want the immune system to attack the cancer. But in this case, it's attacking an organ that could be, potentially fatal. Your oxygen levels are low. Your liver enzymes are up, meaning your liver is inflamed. And so we need to pull back on that immune system. So how do you manage a side effect? So one is, back to the previous slide, is how serious is this side effect? And there's some where it's black or white. This is inflammation of your heart. This is inflammation of your lungs. This is inflammation of your liver. This could become potentially life-threatening. Even in patients who we can see the tumor on scans, they have liver metastasis. We are holding therapy because at this point, this immunotherapy is causing serious damage. And then there's other side effects that we think is, you have joint pain, which is just a common one we see and talk about with patients. And you have a big liver tumor that we can see on scan, or you have a big tumor that we can see. how aggressive are we going to be? You have the, can we get by with a little Tylenol? Can we, and then continue immunotherapy because we have this big tumor to attack, versus somebody who we are giving immunotherapy in the adjuvant setting, meaning we have removed your tumor, as Dr. Lang and Dr. Scharfman has discussed. We think it's at high risk that the tumor can come back or that the melanoma might be out there, but we don't see anything on scans. And so how serious is the side effect and what we do about it really depends on, is it life-threatening? How much is it impacting your quality of life? And what is your tumor burden? Is there a lot, is this tumor imminently life-threatening in the coming weeks to months? Or are we not really seeing on you on anything on scans and there is a potential that you are cured already? So supportive care, topical steroids for itching. Some people get dry eyes, dry mouth, dry eye drops, mouth washes, mouth rinses. It really depends on where you're having the side effects. The life-threatening requires holding a therapy typically and starting immunosuppressive drugs. The caveat here is endocrine toxicities. So in patients where they have their endocrine system is impacted, meaning that the immune system has attacked your thyroid, where your thyroid levels are off, your immune system can attack your pituitary glands. So you're no longer making cortisol, and cortisol is your fight or flight hormone. It's what keeps your blood pressure up. It's what keeps you going. If you don't have enough cortisol in your body, you are not functioning. Another endocrine toxicity that we see, although not quite as common, is a pancreatitis. Immune system attacks your pancreas, causing an insulin deficiency. You're no longer producing insulin. So it's like a type 1 diabetes. Also life-threatening. But in these situations, we can actually just replace the hormone. We can give you some hydrocortisone, we can give you some insulin, and then we can move on with immunotherapy. And then close monitoring. Okay, so what else should you know? So there are side effects that we see in oncology all the time. In the melanoma clinic at Hopkins, we give immunotherapy multiple times a day to multiple patients. So we have seen a lot of toxicities. We are, depending on the provider, we're pretty comfortable with managing some of the common side effects, dermatitis, colitis, but we often have to bring a subspecialist involved into the picture. In the 10 years I've been here, when I started here in 2016, we were giving a lot of prednisone steroids for a long, long time. So patients would be on, for colitis, inflammation of the colon, they would be on steroids for several months. We would be continuing it for a month and then increasing the steroids again. And over the past several years, we have really evolved in our treatment of these itises, these immune toxicities, and we've started giving biologics sooner, so we can get patients off prednisone and sometimes even then be able to continue the immunotherapy in some cases. So we have actually relied more and more on subspecialists, including rheumatology, gastroenterology, some are more dermatology, to help us start some of these additional, more targeted immunosuppressive agents to more effectively treat the side effect and allow us in some cases to not cause as much immunosuppression and sometimes continue the immunotherapy. Hospitalization is sometimes needed. There are some side effects where we think that this could be life-threatening in the next couple of days. We need to bring you in. You need IV steroids. We need to monitor you closely. You need a specialty referral that day. One of those is, without question, myocarditis, inflammation of the heart. We are bringing people to the hospital. I think colitis is one of those things, oh, it's just some diarrhea. And sometimes it is just a little diarrhea, a couple times a day, start a little steroids and you're doing okay. But sometimes the colitis can actually become life-threatening, multiple stools a day. You could have perforation of the bowel. So it really is nuanced, the side effects really can range from something mild to something where we need to bring you into the hospital. Side effects can be short-term or long-term. So is holding immunotherapy enough? One dose study when nivolumab was still in trial back in the day, over a decade ago. They measured how much of that drug was in your system over a couple of months. So when the drug nivolumab was given in your blood serum, the nivolumab exited your system within a couple of weeks. However, this is not about the nivolumab circulating in your blood, as we discussed. This is about the drug, the immune checkpoint inhibitor, attaching to your T cells. And they found that after one dose of drug, your the immune checkpoint inhibitor, nivolumab, was attached to your T cells at the same level without decreasing for at least 60 days. Meaning, one, it's okay to hold the drug for a couple of weeks while we're working on, is this a potentially life-threatening side effect or not? The immune system, this stays in your system for months and months and months, even after just one single dose. It also means that holding immunotherapy is not enough. We have patients that 3 months, 6 months after their last dose of immunotherapy are still experiencing side effects. There are some rare cases where people are still seeing our rheumatology team 5 years after stopping immunotherapy to still manage their inflammatory arthritis. So it's good in the fact that your immune system remains active against the cancer just after a small amount of this drug for a very long time. It's bad in the fact that holding immunotherapy is not enough often in managing the side effects. Experiencing a toxicity isn't always a bad thing. There is some evidence, it's not a causation, but there is a correlation between people who have a side effect also seem to have responses. That's not always the case. But I like to see somebody coming in with a little itching after their first couple doses, a little bit of mild rash. It means your immune system's active. It's doing something. It's woken up. And then, so my last bit is kind of knowing your part. And I always tell patients it is their job to report a new side effect. If we see, every 3 to 4 weeks on average, sometimes drugs are given every 6 weeks, which is a bit of a long time. So we ask you to contact us when a side effect happens. Side effects tend to snowball, meaning they start off mild and then they get worse. So if you have a new diarrhea, you woke up with 3 episodes of loose stool before noon, or even just 1 episode of diarrhea for a day for the past 3 to 4 days, that's something to call us about. Don't wait till we see you 3 weeks from then. Because it's something that could get worse, or it might not be related to immunotherapy. It might be an infection. We could have kind of worked it up, treated it, and then allowed you to continue immunotherapy versus kind of being behind the game. So when you have a side effect, let us know. It is our job to know what to do about the side effect. So your job is to report. Our job is to know what to do. So save your clinic phone number. We often give out, most clinics, at least at Hopkins, we give out a folder. Papers get lost. I tell people to put the clinic numbers on call, daytime, nurse triage in their saved phone. Know when to use MyChart. This is an increasingly common form of communication. It's great. We are typically at Hopkins very quick at responding to it, but there can be delays. So if you wake up with a mild itching, it's just a little bit annoying, probably good to send a MyChart message. If you wake up and you're having 6 episodes of diarrhea that morning, that's probably a time to give our nurse triage a call. When do you call in the evenings and on weekends? I tell people if they have something where they are worried that they have a side effect that could be potentially harmful, give us a call. We have a Hopkins on call, evenings, weekends, holidays. And what to do if you go to your local hospital. So basically, whenever you call a medical clinic and they say, is this a medical emergency, call 911. So if you cannot breathe, if you are suddenly confused and you don't know who you are or who the people around you are, if you're having chest pain, you call 911. And then you contact us, or you have a family member contact us that you are going to a local hospital. I think it's often helpful to have, there's immunotherapy wallet cards, but you don't always need to have that, just to have the name of your oncologist their triage number, and what drugs you're receiving. The one thing that's important to know is even if you got, which we talked about short-term or long-term side effects, that even if your last dose of treatment was 3 months ago and you're having a new side effect, again, this drug can stay. So if you're going to the hospital with something that's concerning, it's important to let the team know at this local hospital that yes, you're receiving cancer treatment. This could still be a side effect. And that's it. So that's all for me.
All right. Thank you, Megan. That was a great presentation. I hope you took home the take-home message, which is keep in touch. The earlier we know something, the better we can wrangle it. All right, so we're going to take a quick break for lunch. It is just out that door to your left. Let's reconvene here in about 20 minutes or so, 15 or 20 minutes, and we'll restart. Button, use the button, got the button, great. All right, we're back. There was only one button on the microphone. I figured it had to be either that or the eject button, and so I'm still here. All right, well, great. Thank you for joining us again online and in person. We're going to get rolling in the interest of time. I'm going to give a very brief presentation about something exciting that is going on in our program right now. Remember I told you when I began this whole spiel that there is a connection between the laboratory research that is done in our program and what we are doing in clinic. What we learn at the laboratory bench impacts what we do in our clinical practice. That's what I'm going to tell you about today in very brief fashion. Okay. So the first thing, Dr. Scharfman alluded to this, the first thing that we learned way back in the day was that there are these little, let's call them inhibitors on immune cells. So the immune cell in this picture is that angry looking dog. That angry looking dog is an immune cell in your body, and it wants nothing more than to go and attack a cancer cell that is developing. But you will notice that the dog is restrained by a chain that's got him chained to the ground. Everybody see that? So the therapies that we use cut that chain. It releases the hounds. It allows the dog to go and attack the cancer cells. So I'm going to tell you a little bit about the way we're using that. The context here is basal cell carcinoma. Basal cell carcinoma, or BCC, believe it or not, is the most common human cancer. Around the world, most common human cancer. Sometimes this cancer gets way out of control to the point where we need medicines like the ones I'm talking about right here, the ones that cut the chain, to help patients battle back those cancers. Several years ago, some investigators took one of those medicines that I'm talking about, those anti-PD-1 chain cutter medicines that I'm talking about, and they tested it in a big group of people who had these horrible basal cell carcinomas. And the way that they tested it was what is called the second line, which means that patients had already been given another kind of medication first, and then they came in and they got those chain cutter drugs that I'm talking about. And what they saw in that trial, in the second line, what they saw in that trial was that between 20 and 30% of people were having a response. The tumors were shrinking in about 20 to 30% of people. So 20 to 30%, you'll say, that's not bad. That's almost a third of patients. However, in the rest of the skin cancer world, that number is way too low. In melanoma, we're seeing 40 to 50% of people whose tumors shrink with the chain cutter medicines. And in squamous cell, it's even higher than that, 45 to 50. And then there's this other skin cancer called Merkel cell, which is awfully rare, but it too responds to the chain cutter medicines 50 to 60% of the time. So why should basal cell be responding at half of that rate? We asked the same question, why should the number be so low? And perhaps it's because the way that they used it was the second medicine people received. Those patients in the big trial I was talking about already got one other kind of medicine, and then they got the chain cutter medicine. Maybe that's why. So as a result, we at Hopkins started a clinical trial several years ago using the chain cutter medicine, but not in the second line. Now we're using it in the front line. And the idea is, could we get those response rates back up where they need to be, around 50%? Here's a guy who's on our trial. He's 58 years old. He has this terrible basal cell cancer on the back of his shoulder on the right side. It was 7 centimeters across when he came to us. We started him on the chain cutter medicine. That's called Nivo, by the way, N-I-V-O. Nivo is the chain cutting medicine. We started him on Nivo, and 3.5 months in, he comes in and his tumor, you can see, is already beginning to get smaller, right? We're making progress in a good way. So he gets his year of therapy. That's just how we wrote the study. He gets his year of therapy, and he comes in again and again and again and again. And 27 months later, we see him for another photograph, and that tumor appears to be gone, right? So we're making progress. He's 27 months, and it's not stopped responding. It's ongoing. His response is ongoing. How long is this response going to last? I don't know. We shall see. That's part of the excitement of a trial, is maybe we give this guy a really, really durable response, years and years and years, perhaps. This is interesting. If you took a little piece of tumor and you looked under the microscope at the beginning of when these guys started, you see all these purple cells. This is a microscopic photograph of all the tumor cells. All that purple is cancer, right? Before therapy is on the left. Look at the 2 weeks into therapy. We took another biopsy of his tumor 2 weeks after he had started therapy. All those green and white and orange dots, all of those little tiny things are angry immune cells, because we had given this guy the chain cutter medicine, and that angry looking cartoon dog that you saw a bit ago, those angry immune cells are destroying those purple tumor cells. So in our clinical trial, we've got about 30 patients on the books at the moment. About 50% of those patients have responded, which means that our hypothesis was maybe correct, that if you use the chain cutter medicine in the front line, not the second line, maybe you're getting the higher response rates that we were looking for. But you'll say, well, the 50% that you're helping, that's great, but what about the 50% that you are not helping? The other half of people that need help. So remember, I told you that we go between bench and bedside. The laboratory stuff that we learn informs the way that we treat clinically. Well, some of our counterparts looked at basal cell carcinomas under the microscope, and they said, you know what, there is another something that is holding back the dog. In addition to that chain that I showed you that had him chained to the ground, there's also a muzzle on your immune cell's face. They can't open his mouth. There is something else that is preventing your immune cells from attacking cancer. So we said, that's interesting. We have a medicine that can remove that muzzle. So we're going to give the chain cutter medicine, and we're going to give the muzzle remover medicine, both at the same time, and see if that works in the patients where just the chain cutter didn't work. Here's this guy who came in with a big basal cell on near his eye. The first stop actually for him was a surgeon. He went to a surgeon and said, I've got this big tumor in my eye. And the surgeon said, well, I can cut that out, but your eye is going to come with it. And the patient said, I'm not up for that. I would like to pursue some other line of therapy. So he came and joined our trial, 64 years old. So he started with the 17-millimeter tumor next to his eye. We gave him the chain cutter medicine, and that tumor did nothing but grow, just got bigger and bigger and bigger. And at this point, he's gotten just the chain cutter. It's now 22 millimeters across. It's beginning to make it so he can't see out of that eye. It's growing across his eyeball. And so we said, all right, we're going to give you the chain cutter medicine, and we are going to add the muzzle remover medicine, and we'll see if that works. So we did. And I tell you, it was like flipping a light switch. Here he is at 10 months, and that tumor is gone. It was quite amazing. At his first evaluation, after getting both of the drugs, he came in, and already you could see that the tumor was beginning to regress. And now we really can't see it. That's why we drew a circle instead of a little caliper there. All right, that's it for me. I just wanted to tell you an example of one of the ways that we are coordinating with our laboratory colleagues to understand the science behind the way cancer grows and how that informs what we do clinically to treat patients just like this. All right, with that, I'm going to turn the microphone over to my colleague, Dr. Govind Warrior, who's going to tell you about some of the exciting drugs coming down the pipeline for our patients.
All right. So thank you to everyone who's joining us here today. Thank you for those online who are sticking here with us. And thank you as well to our amazing melanoma skin cancer program, in particular, Dr. Lipson and Maura Caden for organizing today's event. The slides up here. So I have the privilege of sharing with you an exciting topic, which is charting new paths, advances in melanoma clinical trials and therapies. You heard a little bit from Dr. Lipson of some of the fantastic work that we are involved in here at Hopkins. Here are my disclosures. Now, I will level set once more with a fundamental idea that you have seen a couple of times from Dr. Scharfman and Dr. Lipson, and that is For a long, long time, in the not too distant past, we were dealing with very few options for treatment of melanoma, just for in particular. That has exploded just over the past 15 years to include targeted therapies. You heard about some of those from Dr. Tao and Dr. Scharfman, immunotherapies. You heard about that a little bit from Dr. Scharfman and Dr. Lipson here as well. But the take that I want to give you on this is that each of these now approved therapies started as a clinical trial. And it was yesterday's clinical trials that really became today's standard approved therapies. And that is because it's not that there weren't trials going on between 1970 and 2010. It's just we learned from each of those examples. And that is what informed the trials that came after. And it really was patients at the center coming together with scientists, clinicians, researchers to say we need to do better. Now, I'll also highlight something else that Dr. Scharfman showed, which is that we have made tremendous progress in how long and how well patients are living with melanoma. That 50% figure that was also quoted to you by Dr. Lipson. But here again, I'll give you another take, and that is we need to do better for the other half. And moreover, even that half that is doing well at now 10 years out, many of those, as you heard from Megan Schollenberger, are dealing with sometimes side effects, sometimes which are life-altering in nature. And so here is why we need to develop the clinical trials of tomorrow. But recognizing that there may be varying levels of familiarity, you've heard the term clinical trials a lot today, but a common question that we actually get in clinic are, what are clinical trials? And the way that I explain it is a little bit like Dr. Lipson said, which is clinical trials are how we move promising, emerging therapies from the lab to helping patients. And moreover, it is a systematic way in which we can do that safely and thoughtfully. Clinical trials strive to answer three simple questions. Is it safe? Does it work? And is it better than what we have now? Right? Those are the three basic things that clinical trials are trying to answer. For your awareness, there is technically a fourth question that we always try to answer, that is, after a therapy is approved, we are always monitoring that agent as it gets out to more and more patients to understand, is there anything else that we need to know, as this is now getting into a larger population. Another question that we often get, when should I consider a clinical trial? Let's think about this in the context of what a patient often goes through, right? We have an initial treatment choice after their diagnosis. We have some active treatment that the patient then starts. And that patient may go on to do well with that treatment, or in some cases, unfortunately, their cancer, melanoma, may grow. Now, the natural tendency, of course, is to think about when that cancer grows, should we consider the next standard of care treatment, or should we consider a clinical trial? You heard about one such trial that we have up and running at Hopkins from Dr. Scharfman, and certainly that is a very important thing to consider. But here, the case I'll make for you is that there's an opportunity to consider trials at each of these junctures. What about that very first treatment choice? You just heard from Dr. Lipson how a treatment that showed promise in a later stage setting is now showing even more promise as a potential first-line treatment. That's our Johns Hopkins study looking at how can we optimize immunotherapy for patients with basal cell carcinoma. What about while someone is getting treatment? Or what if they actually do well with their treatment? What if there was a way in which we could still make that process better for them? What if we could monitor, or predict if they were going to do better with that treatment earlier than waiting for the next scan? Or someone that does do well with the treatment, where we always have that monkey on our back of, is this going to come back? What if we could better predict who is at risk of having this come back or not? We actually have a trial for that at Hopkins. We're trying to work on developing blood tests to predict response and recurrence, and even who may develop side effects. So again, I say this to drive home the point that clinical trials can be considered at every juncture. Now, clinical trials are never an obligation, but they're always an opportunity. And I think it's beholden on us to make sure that people are aware of these opportunities at each juncture of their care. Now, I'm going to talk to you a little bit about those last two items, and that is just highlighting two frontiers in melanoma that I think are particularly exciting, for which there are clinical trials coming out. One, you've heard a lot today about immune checkpoint inhibitors. What I want to talk about is personalizing therapy a little bit more. So at the end of the day, the immune checkpoint inhibitors have been revolutionary, no doubt, but they still serve as a singular mechanism that you are trying to use for a lot of different people. And we know, as you heard from Dr. Tao, that every melanoma is a little bit different, every cancer is a little bit different, and what makes one melanoma tick can be different from somebody else's. One approach that we're trying to use to get at this is actually trying to make therapies that are individualized to a given patient's melanoma. So this is actually based on some of the same technology as the mRNA vaccine. Neoantigens, you can think about neoantigens as sort of the fingerprint that make up a given melanoma or a cancer. So first, physicians or doctors take a sample of the patient's tumor and blood so you can identify and understand exactly the unique genetic mutations of that cancer. An analysis is performed to understand what might be the best cancer fingerprints that may train and activate the patient's immune cells. And an individualized therapy is made for the patient. In this case, I'm going to talk to you a little bit about the mRNA approach to this. And that is given back to the patient, sometimes alongside an immune checkpoint inhibitor, to give it a more targeted angle at helping that specific patient. So this is not to overwhelm you with details, but just to show you that clinical trials sometimes get a little bit complex. But to show you that at the end of the day, what we're trying to do is improve upon a standard of care. I say this because a lot of times another question that comes up is about randomization, and patients rightfully ask, well, I don't want to be randomized to a placebo type of arm. And what I will highlight is that I think we, trying to be good stewards for our patients, always want to ensure that if we are considering a trial, that the randomized portion of that trial is always at least the standard of care that they would receive. And that is the case in this particular trial that we had up and running at Hopkins that Dr. Scharfman was actually leading. This is an international trial that just wrapped up its recruitment. So in this study, patients with high-risk melanoma, as you heard from Dr. Lang, stage 3 or 4 melanoma that was actually removed with surgery, were randomized 2-to-1 to one arm got the standard of care 1 year of immunotherapy to try to prevent or delay that melanoma from coming back. Other arm, 2/3 of patients actually received an mRNA neoantigen injection that was designed based on proteins that their specific melanoma expressed, along with the 1 year of immunotherapy. And what I'm showing you here is if we start at 100%, the top left corner of patients who did not have their melanoma come back, and we followed them for a number of weeks, as you see on the bottom there, that top line are those that received the mRNA injection combined with the immunotherapy. The bottom darker line are those who received just the immunotherapy alone. The proportion of patients who remained without their melanoma coming back was considerably higher in this phase 2 trial. I'll put it to you in a little bit different way as we had a little bit more follow-up. After 2.5 years of following patients on this phase 2 trial, 75% of the patients who received that combination remained without their melanoma coming back compared to just 55.6%. So this was a promising phase 2 trial, and the phase 3 that we participated in was launched based on those results. So an exciting example of personalizing an approach, and I think represents one such attempt at doing this that's going to be part of the next frontier in melanoma care. Let me talk to you about something completely different for the next exciting frontier, and that is turning viruses into cancer fighters. So busullimagene odereprepvec, RP1 mercifully for short, is engineered from actually a strain of herpes simplex virus type 1. So this is completely harmless to humans, non-infectious to humans, but what scientists in the lab discovered is that this particular strain of the herpes virus could actually destroy cancer cells. And what is so interesting is that if you inject this into a melanoma lesion, not only does it destroy the cancer cell, but actually the virus will then sort of burst out of the cell and keep going after other things that might be nearby. And I'll credit AIM at Skin Cancer. Actually, this was a nice figure from their website highlighting this mechanism. So this was actually a trial that is now up and running at centers near ours, where it is looking at the ability of RP1 to kill melanoma cells even after treatment with prior immunotherapy. So these are patients who had prior immunotherapy. They unfortunately had their melanoma grow despite that treatment, who then received injections into their melanoma combined with another immunotherapy, nivolumab, and they were followed over a number of months. Here's one such patient who was treated in that trial. She had stage 4 melanoma, and you see that lesion there. That lesion that was a deposit of melanoma was injected with this virus. And several months later, you see that it has essentially melted away. Now, I mentioned to you this was a patient with stage 4 melanoma. That means she had involvement of a lot of other areas of the body. And what I'm showing you here are a lot of non-injected sites of the melanoma. So you're seeing little snapshots from a CT scan where you're seeing a spot of melanoma in the liver, lymph nodes, et cetera. And the interesting and really exciting bit here is that even in those non-injected lesions, you saw destruction of the melanoma. And so this is the ability of that virus to propagate, destroy the melanoma cells, leave those cells, and everything that is exposed from those melanoma cells dying and sensitizes the immunotherapy. And again, highlighting this is in patients who had their melanoma grow despite prior immunotherapy. So pretty exciting stuff here. Now I'm going to shift gears a little bit for the last little bit of my talk. And that is I've just shown you two very exciting examples of clinical trials. Certainly I could have covered 20 more, but for the sake of this 20 minutes, I just want to hit the highlights. But what I want to highlight is thinking about who actually participates in clinical trials in the United States. I won't put anyone on the spot, but I just want you to think in your mind what proportion of patients with cancer actually participate in a trial. That number actually happens to be right around 6%. So we talk about clinical trials a lot, but the vast majority of patients are not participating in clinical trials. Now I will highlight there is some bifurcation here. This number looks quite different at community cancer programs, 3.6%, versus of course, centers like ours where primary focus is developing and building and enrolling patients in trials. It's still higher. But I would posit to you that both of these numbers are still actually abysmally low. And I say that because when you poll patients with cancer, about 70% of them, it turns out, would actually say they are interested in potentially participating in a trial. And actually about 50% of all cancer patients are likely eligible to participate in a clinical trial. And so we have a huge population that we need to get the word out to consider these at every point of their journey, as I mentioned. Now, there are a lot of great folks trying to help with this. Some of you may be familiar with the clinicaltrials.gov website. This is a public-facing website that actually hosts information about every clinical trial out there in the world. But I don't know if you have traversed that site. It is extremely difficult, to say the least, sometimes to get the information that you need. And I say that for myself as well. But there's certainly a lot of great nonprofit groups and industry partners in melanoma, American Cancer Society, that are trying to work on the navigation piece of this, trying to help patients get to trials that may be appropriate for them. Here at Hopkins, I'll just highlight we're working with a partner, 1104 Health, at trying to develop a platform to help patients and their local medical teams connect with our specialists and clinical trials a little bit better than what is available right now. So with that, I'll just take us back to the slide that I showed to show all the advancements again that have been made, of course, over the past 15 years. But I will highlight for you, and I'll leave you with a closing note, that we are just at the beginning. Over the next decade, we're going to see the next wave of personalized therapies, the next generation of TIL therapies, MTAC therapies, BiTE therapies, lots of exciting stuff coming down the pipeline. But getting all of those approvals requires brave patients, including many in this audience, that are really willing to invest the time and advocate for themselves and other patients with melanoma to move the field forward for everyone else. So with that, thank you very much for your attention. Glad to answer questions.
Thank you, Dr. Warrior. We will have time for some questions toward the end, so keep them coming online, and you can write them down here in the live audience. Next up is Stephanie Hausnecht, one of our intrepid pharmacists. And pharmacists, as a part of our team, are indispensable. They provide us with information about therapies and toxicities and administration of drugs, and they help us coordinate with patients about starting medications. It is part of our multidisciplinary team. So we are delighted to have Stephanie join us today. Thank you.
Thank you, Dr. Lipson. Thank you to Mara for inviting me. I will make a disclaimer as one of our other speakers did. I am actually a thoracic pharmacist. However, there are a lot of overlaps between melanoma and lung cancer, and most of the therapies that we use in melanoma, we use in lung cancer as well. So I knew I was kind of coming at the end of the session today, and I knew that a lot of the colleagues coming before me would talk about therapy. So I was thinking to myself, what would be the most useful for your time? And that is for you to walk away with an understanding of what a pharmacist can do for you as a patient, and also for you to have an appreciation of how we interplay with your whole care team. Okay, so we go to school specifically for drug therapy. So we have been called the cancer medication experts. I think what's really important to know, though, is that we are a collaborative member of your healthcare team, and we help your team to make evidence-based decisions that are individualized to you as a patient. I'll give you some examples of how that can come into play here in a bit. We also help to bring new therapeutics to the healthcare system, both efficiently and safely. So Dr. Warrior talked about all of the agents coming down the pipeline. And a recent example is the tumor infiltrating lymphocyte therapy, or TIL therapy. Pharmacists play a role in bringing that through formulary at a place like Hopkins and making sure that we can deliver that therapy to our patients both safely and effectively. We help with 4 main pillars. We can provide drug information, not only to patients, but to the care team. We help with medication access. That's a big thing. It doesn't help for you to be recommended for a therapy if you can't actually get access to that medication. We do a lot with education of both patients and caregivers. And then we also help your care team with longitudinal monitoring. You've seen different iterations of this slide, but these are all the therapies that we have available, and I've put them into boxes based on broadly how they work. We have our checkpoint inhibitors, which are broadly speaking our immunotherapies. We then have our targeted therapies, in particular for patients who have those BRAF mutations. We have our tumor infiltrating lymphocyte therapy, which Dr. Scharfman spoke about. It's one of our newer therapies. And then we have our traditional chemotherapies. And these are different, despite the fact that I see a lot of misinformation, even amongst radiologists and emergency medicine doctors. These therapies work differently, and their toxicities are very different. Very briefly about medication access, because I could spend an entire hour plus talking about this, but I think this is important for patients to know and understand. And unfortunately, we don't have a good system in the United States for educating just citizens. I mean, I think we should probably be teaching this in high school. But navigating health insurance can be really tricky. We have 2 main branches. We have our medical benefit and our prescription or drug benefit. So regardless of whether you are a Medicare beneficiary over the age of 65, or you have commercial insurance through an employer, you will have a medical benefit and a prescription benefit. Infusion therapies, so therapies that you have to come into the clinic to receive, those are billed under your medical benefit. So if you have Medicare, that's Medicare Part B, as in boy. And Medicare covers 80% of the cost of those therapies. Now, for that other 20%, most people will enroll in a supplemental plan to help to cover those costs so that there's not a lot of out-of-pocket costs. Oral therapies, which I think are very poorly understood as far as medication access, they are covered under your pharmacy benefit because they can be self-administered by the patient in the home. You don't need to have us watch you take a pill every day or have a nurse administer a pill to you every day. So these therapies are covered under Medicare Part D, as in dog, and you have to sign up for a separate pharmacy benefit if you're a Medicare beneficiary. And open enrollment is going to be starting here soon and going through the beginning of December for 2026. The BRAF MEK inhibitors, of which there are 3 couples, they are specialty medications. That specialty medication designation means that it comes with a lot of red tape behind it, okay? These therapies are very expensive. They're anywhere from $10,000 to $20,000 a month out of pocket. And so they have a very specific process for the insurance to ensure that they are being used appropriately and that a patient is a good candidate for them. That usually involves a prior authorization process. So just because a physician is ordering them does not mean that the insurance will automatically approve them. They often ask for some additional clinical information, and that can take anywhere from 24 to 72 business hours. Assuming we're able to get authorization through the insurance, these specialty medications often have to be dispensed by certain specialty pharmacies. You can't go down the street to Walgreens or CVS and expect to pick these medications up. They also may be associated with high out-of-pocket costs, and that is because they Medicare Part D, you can't sign up for a supplemental plan for Medicare Part D, right? So whereas infusion benefits, you have 80% coverage by Medicare, 20% with a supplemental plan, Medicare Part D is kind of standalone for drugs. The good news is that pharmacy team has a lot of individuals that work through medication access, and there are resources out there through both pharmaceutical companies as well as grants and charity organizations. So you might be eligible for a patient assistance program, a grant, or a copay card to help offset some of those out-of-pocket costs. Okay, we talked about BRAF/MEK inhibitors. I just wanted to kind of give you an overview. In the top in blue are some of the class effects. So there are 3 different couples: vemurafenib, comimetinib, dabrafenib, trametinib, and encorafenib, binimetinib. They in general are pretty well tolerated therapies, but they do have some unique toxicities. Some patients report fatigue. We can see rash, diarrhea, and joint pain. There's some rare toxicities. These are the things that I usually talk to my patients about, and I want them to understand what sort of symptoms we would want them to report. But things like inflammation in the lung, a side effect called pneumonitis, can be seen. Sometimes patients can have blood clots or have increased risk for bleeding. And these medications can reduce your ejection fraction, the heart's pumping efficiency, so something we need to monitor for. And then they rarely can have some unique eye toxicities or ocular toxicities where we might need to get you in to see an eye doctor. And then each of the individual combinations have some own unique toxicities, and that's kind of where pharmacists come into play. We'll look at a patient's profile, we'll look at the medications that they're on, we'll look at their comorbidities, other conditions that they have. We might pick out something that your doctor might have missed or didn't consider that would push us to prescribe one of these couples over the other. Some things that are unique: vemurafenib, we can see photosensitivity reactions, tends to be a little bit higher incidence of having elevated liver function tests. With dabrafenib, trametinib, this is the pair that has the famous fevers and chills. So you can see drug-induced fevers that can be really bothersome for patients and can recur. Also, if a patient has comorbid diabetes, maybe not the best bet because this pair can cause elevated blood glucose. And then with encorafenib and binimetinib, these are our newer pair. They're generally speaking better tolerated. I thought I heard Dr. Scharfman say they're his preferred couple, but they can prolong the QT interval. So if we have a patient who has a borderline QT interval on EKG, that can set them up for an increased risk for arrhythmias. That might be something that we have to monitor more closely. Or these combos can cause an elevation in creatine phosphokinase, which is a lab marker that can be an indication of muscle inflammation or damage. I know Megan talked to you about immunotherapy toxicity. So just as a reminder and a refresher, when we give checkpoint inhibitors or other immune-based therapies, we can see inflammation anywhere in the body, right? We want to engage T cells to fight the cancer, but we can sometimes have those T cells go a little haywire, and we can see any of the itises from top to bottom. I think what's important to know is that these toxicities are readily treatable, especially with prompt reporting. So we talked about prednisone and steroids and how they're kind of the mainstay of calming down that inflammation. We want to start them early. We don't like patients to be on them long-term though, because they can be associated with some complications and side effects. I think it's important to know that when we use these steroids for the treatment of toxicities, they don't appear to reduce the response to the checkpoint inhibitors. When we first started using these widely in the clinic, I would always worry that patients wouldn't want to report certain side effects to us because they didn't want us to stop their checkpoint inhibitor therapy for fear that we would maybe lose control of their cancer. But when we are using them to treat toxicities, that does not appear to be the case. But we generally don't want patients to be on other immunosuppressants for other causes. So Megan also mentioned that we don't really like patients being on steroids for a long time. So if we see a patient that's going to have to be on prolonged steroids because of an immune-related toxicity, we might add another biologic immunosuppressive agent. That's where pharmacists can help come in to play, getting access to those. But if you are on steroids, pharmacists are going to be in the background making sure that we're not causing more problems with the treatment of your toxicity, right? So we don't want these iatrogenic or treatment-induced problems to occur. So we're going to be thinking about all the supportive care of someone that needs to be on steroids while we're getting their checkpoint inhibitor toxicity under control. We want to make sure that you know you're taking your steroids with food, that you might need to have acid suppressant medication. We're going to be thinking about infectious disease risk from prolonged steroids. If you're diabetic, we're going to be making sure you have good glucose control. And we're also going to be making sure that we're considering your bone health and decreasing your risk for osteoporosis, making sure you're getting adequate calcium, vitamin D. And that leads me into supplements, right? Because unfortunately, a large part of my job is answering questions from patients about supplements, okay? So this is my plea to you. I am begging you. The supplement industry is not regulated, okay? The supplements can come to market without any scrutiny, and anybody can sell anything on Amazon or any internet site, okay? None of the claims that the supplement industry makes has to be substantiated, and not all supplements are safe, okay? So just to go over a few ways in which supplements can harm the drug therapy that we want you to be on. They can cause medications to break down faster, right? So if you're on one of the BRAF/MEK inhibitor combinations that I mentioned, some supplements can actually cause the drug levels to decrease because of interactions in the liver. Sometimes they can do the opposite. They can actually slow down the metabolism of the prescription drug, which could increase your risk of side effects. And then some supplements just contain contaminants that are themselves toxic to the liver. So two important resources that I do trust, that if you do want to do your research, the NCCIH has an Herbs at a Glance website that has about 50 different common herbs and supplements. It's written for patient-friendly language, and it goes through what is known about that herbal or supplement and what are the potential risks or drug interactions. And then Memorial Sloan Kettering, which is a NCI designated cancer center up in New York City, they have a site called About Herbs that also has a patient-friendly facing portal. There's more than 300 herbs or supplements there. So if you are interested in a particular supplement and you want to try to do your research, these are two resources or references that I trust. Here's just an example. And this is truly a supplement that I was sent by one of my patients last week, okay? First and foremost, warning sign, proprietary blend. Okay, what does that mean? Okay, I wouldn't give you a cup of coffee and say, well, it might have 50 milligrams of caffeine or it might have 500 in it. I don't know, right? It's my proprietary blend. You don't want to take anything that says a proprietary blend, okay? One ingredient here, and I just pulled a couple of them. One ingredient has estrogenic properties. So if a patient has a history of breast cancer, that could be concerning. Some supplements can have anticoagulant properties, which could increase your risk for bleeding and is a problem if you're on a blood thinner medication. Sometimes we have drugs that can inhibit drug efflux transporters. So again, that's a way in which it can lead to drug interactions. We also have supplement ingredients that can interfere with liver metabolism. And then finally, I did actually pull the research for this. I went to the company's website and I was just kind of say, what are they putting out there? What are they trying to sell to patients? Kind of what's the grab? And if you read the fine print, because they are touting that this was studied in well-controlled clinical trials, which kind of question that. But one thing they specifically said is while they didn't find any side effects from this particular supplement, they did not study the way in which this supplement affected the anti-cancer agents that the patients were on, right? So they were marketing it to patients to decrease the risks of chemotherapy side effects, to recover blood counts faster, but they never looked at whether there was any adverse impact on the cancer treatments themselves, okay? So just an easy example of ways in which we really want to try to avoid these types of supplements. Another one, this stands out to me, melatonin supplements. So this is from our neighbors up north. This group of researchers took over 30 different supplements that they could buy at grocery stores and pharmacies in Canada, and they sent all of them off for laboratory testing. The melatonin content of the different supplements varied from having 17% less of the melatonin than it said it did on the label to more than 5 times the amount of melatonin that it said it did on the label. Okay, less than 70% of them actually had within a 10% range of what was labeled. And what's also concerning is you think, okay, I find a product, it works for me, I'm going to stick with that brand. Well, even between lots, so from lot to lot of the same product, the amount of melatonin in the supplement could differ by as much as over 450%. So this is my plea. If you are considering supplements, have a valid reason to do so. There must be some reason you want to take a specific supplement, whether it's to increase what you think is increasing blood counts or to improve energy levels. Make sure you at least have some valid reason, not just that your sister's friend recommended it or she had cancer and this, helped her, et cetera. Do your research and be wary of bold marketing claims. Generally speaking, if something sounds too good to be true, it is. And then always make sure you're purchasing supplements from a reputable source with third-party testing. What is third-party testing? That's where the company pays money to go send it off to an independent lab to verify that what is on the label that they are putting on the product is actually in the label, okay? And that costs money. So generally those supplements do cost a little bit more, but then you have the peace of mind that at least you are getting what you are paying for. How else can you utilize your pharmacist other than asking me to review your supplements? Make sure that you're comfortable asking us questions, right? We're very accessible. We've been called one of the more accessible healthcare providers, and that's because we are generally in clinic 5 days a week. We have heard absolutely everything. I mean, I can't even repeat some of the questions that I have been asked, but there is no stupid question. I know that this is overwhelming to a lot of patients, and I am more than happy to spend the time to answer the questions that you have. It's okay to ask for a clarification. So if you had your visit with your doctor, you wrote down some notes and you're kind of going back to them and something doesn't make sense, we're happy to help clarify things there. Always bring a care partner with you, somebody who's having another ear open to listen to the things that are being said, because again, we know that this is overwhelming. And always inform us when you have new medications or supplements that you're prescribed. So if you can't keep your doctors all within the same health system, let us know when maybe a general practitioner or an urgent care facility has prescribed you a new medication so that we can make sure that there's no issues with your prescription drug products. With that, I think we're going to hold questions for the end. As I mentioned, I am not the melanoma pharmacist, but there is one now, and we are always happy to answer any questions that you have, and my chart's a great way to get a hold of us.
That was super informative. I did not know all that about supplements, but now I'm going to be super wary of all the. Anyway. All right. So to wrap things up, our social worker, Laura Vo, is going to join us and talk about the resources and elements that the social work team contributes to the holistic care of patients that we try very hard to provide. So with that, Laura.
Thank you. Hello. I'm honored to be here today with all of my colleagues and to be presenting. Wait for my slides to pull up. I have no disclosures, first and foremost. I'm a social worker. We usually don't. So I'm going to be presenting on caring for the whole patient. As social workers, we are trained to consider our patients within the context of their environments. So we want to think about your relationships, your work life, your family life, spirituality, hobbies, your past, as well as your future. In cancer care, we want to ensure that we're supporting our patients in as many of these domains as possible. So here at Johns Hopkins, at the Sidney Kimmel Comprehensive Cancer Center, we have oncology social work, such as myself. Most cancer diagnoses have their own designated social worker. We have oncology chaplains. We have Living with Cancer programming and the Hackerman Pat's Patient and Family Pavilion. When we work with our patients, we think about the whole team and what everyone has to bring to the table. So at the top there, we have the things I previously mentioned, your social workers, chaplains, cancer programming. We also help with transportation and housing assistance. A lot of health insurance plans can offer transportation. Counties can as well. We have local centers for housing during treatment, and we can also give information on general housing. Our pharmacists, who you just heard from, patient financial assistance, does a lot of work with insurance. As was mentioned, open enrollment is coming up. Next week is when open enrollment starts for Medicare, Medicaid, as well as Affordable Care Act plans. There's a lot up in the air right now in the news about some of these programs. It is our job as social workers to stay on top of those current events so that we can be a resource to help explain changes that may be coming. We have behavioral health. We offer counseling. We can also get our patients connected for substance use or misuse clinics, patients, caregivers, other family members. At Hopkins, we have a psychiatric liaison nurse, specifically in oncology. We can provide information and assistance with any legal things. We do advanced healthcare directives. I'm often found running around the inpatient floor with a stack of them, trying to get people to fill them out. It's a vital component to your health. We also have notaries, advocacy, and we can get you connected to legal programs. Financial counseling, as I mentioned, with insurance, as well as just finances in general. We have home care coordination. They can help with getting you set up with in-home nurses paid for through your insurance, as well as any durable medical equipment that you might need. Care management are inpatient nurses, and we work closely with a palliative care department, both inpatient and out. As social workers, we do psycho-oncology care. So that is what I explained at the beginning, which is how do we care for you as a whole person? When you're going through cancer treatment, it's not just the medications, it's not just the appointments, it is, are you still working? How can we help get you into treatment and get you connected to FMLA resources if you're working? Explain what your benefits and your legal rights are. We do a lot of the psychosocial assessments. So an assessment is just an interview, questionnaires or surveys that we use to try to get to know our patients better. This helps us as social workers to guide you through any supports you may need. It also helps us communicate with your medical teams. Someone may tell me, I keep getting scheduled for appointments on Tuesday. I can't come in on Tuesday. My child's school ends at 12 o'clock on Tuesdays. And so we can help relay that information to get people the type of care that they need so they can keep doing their things outside of being a patient. Our counseling at Johns Hopkins is pro bono on a short-term basis. Sometimes patients just need 1 or 2 sessions. I have several patients who I meet with on a bi-weekly basis, individual as well as couples. Family meetings and advanced care planning and goals of care is all a big component of what we do. At our goals of care meeting for treatments, if we're going to change it, if a treatment's no longer working, if our goals of care entirely have begun to shift, social worker is a vital part of that team to have those conversations. And we look closely at social determinants of health. We don't want anyone going through cancer treatment if they don't have access to food at home, if they need help with finding stable housing. So when we assess our patients, these are all of the things that we are trying to assess for. Ideally, we don't go through a checkbox on a piece of paper. We just have a conversation and we get to know you better through the conversation. We also help with school-age children. That's a big one, with talking to younger children about a cancer diagnosis. We have resources like books, coloring books, even picture books, to help explain to children at different lifespans what a cancer diagnosis is and what it means to go through cancer treatment. As I mentioned, we have those legal and work concerns we help with. Our chaplains do a fantastic job with spiritual and religious needs and concerns during treatment. Complex family systems, we all have them. And sometimes things can just be a little more challenging on top of a cancer diagnosis. And so we're here for those conversations as well. At Hopkins, we have a Living with Cancer survivorship program. We consider survivorship to be day one of your diagnosis and throughout the trajectory of your care and after care. Every June, we have a Cancer Survivors Day. It had been virtual, but this past June, we were able to bring it back to in-person. It's open to all types of cancer diagnoses for patients, caregivers, family, and friends. We do educational events with webinars and conferences. We have a monthly newsletter. And we have our resources page, which is a wealth of information. Many of our resources are similar to the resources you can find at the AIM at Melanoma's website as well. So as I mentioned, we do a lot with transportation during treatment, especially if someone is receiving one of the more specialized cares, like a TIL procedure. You need to be a certain distance from treatment. You cannot drive when you're on treatment, and you're the main driver for your family, or you're the only driver in your family. How are you getting to and from appointments? So a lot of these problem-solving types of things are the conversations that we have with our patients. We also have a new program called MAPS. It is a mentorship and peer support. What we heard from a lot of patients was that they wanted to talk to someone who's had the same or similar diagnosis as they have. And so this is a way to get our patients connected to someone who has also gone through their exact type of treatment. They can talk about, yes, I also had those side effects similar to what Megan shared about. And they can be a great guide and resource for that. So anyone is welcome to join the MAPS program as either a mentor or looking for a mentor. Pat's Patient and Family Pavilion is basically a home away from home for those who need to be closer to treatment. It's short-term temporary housing. The room rate started about $60, and for an entire apartment, it's $85. It's much better than the hotel rates that you'll find around here. And it is only for cancer patients. So they have communal dinners with a chef who comes once a week. It's a really nice, welcoming environment. It's something that myself or my other colleagues can help get patients into. If you are not at Johns Hopkins, there are a lot of organizations called Hope Lodges. And those are in major cities throughout the country that also offer housing opportunities for patients undergoing treatment. You might want to take some screenshots or photos of these if you want some resources in particular. I put the main ones that I refer patients to. These are generalized resources. They will help with emotional support. They have support groups virtually that they do. Also, general information about your type of cancer in particular. And I should mention, these are national programs. The Wellness House is a national program, but I put the Maryland one up in particular. A lot of patients use them for in-person support groups. Financial resources. Keep taking photos, keep taking your screenshots. These ones are fantastic. They can help with any number of things. A lot of them do copay programs. They will do assistance with transportation if you're too far from a catchment area for other options. It can help with prescriptions. And don't worry, there's even one more page of financial resource options available. And so most cancer centers have clinical social workers on staff. So if you're not at Hopkins and you haven't met with a clinical social worker, don't be shy to ask your team. They likely will have one. We're a great resource to help get you through all the other aspects of your cancer care beyond just the medication.
All right, excellent. Thank you very much, Laura. So let's do this. Why don't we take a 5-minute break? There's our proprietary blend of coffee in the next room. Just kidding. We'll come back here in 5 or 10 minutes. We'll answer some questions and we'll wrap it up.
Yeah, I do. I need the slide advancer. Hi, everyone. We're back. I thank you so much for a few moments of your time to talk about AIM at melanoma before we get to the questions. There have been lots and lots of questions that have come in online and a few from the room. Thank you so much. It shows how interested and engaged everyone was in our program today. Thank you again so much to Johns Hopkins and to all of our wonderful presenters for these presentations today and all the moments of hope that we got to enjoy, which is so important to us as we move closer and closer to a cure for melanoma. So I am Ann Garst-Taylor. I'm the Director of Community Engagement for AIM at Melanoma. And for those of you who don't know our origins and why, who are we, why do we exist? 20 years ago, Val Gild's daughter was diagnosed with melanoma at the age of 25. At that time, there was only one FDA-approved treatment, and unfortunately, she did not respond to that. And so after she passed away, Val decided that she was going to form an organization that had two purposes. The first and the most important one was to find a cure for melanoma. And so there are two things that she initiated that they're very unique to AIM that I want to tell you about. The first is that she founded the International Melanoma Working Group, which is a team of researchers that meet twice a year from all across the country so that they can talk about the research that they're doing and we can get closer and closer to a cure. And the second thing is that those researchers told her that they needed a tissue bank from which they could draw tissue for research. And so she founded 5 tissue banks across the country where we are collecting fresh frozen primary tissue. We're almost ready to be able to disperse that to those researchers. The other thing that we need to be able to do, though, is support people who are living with a melanoma diagnosis to make sure that they have accurate and up-to-date information for that treatment journey. And that's what I want to go over with you for just a moment now. So what you're going to find is you're going to find our website where you're going to find these resources available to you at no cost. And in addition to information about research that's going on and the legislation that's going on, a lot of information about education and support. And that looks like a very, very dense soup to nuts website that primarily people come to because they need to know about staging, related treatment, side effects. And we have side effect management guides that are available for them. Also, Dr. Warrior talked about clinical trials. We have a brand new section that goes in depth about clinical trials. We have a clinical trial matching service that we can connect people to so that you can find a clinical trial if you'd be willing to go from that 6% to the 18% that we're looking for. Also, we have an important service called Ask a Medical Expert. Melissa Wilson is a PA that works with Dr. John Kirkwood at UPMC, and she's willing to answer those questions that you just didn't get an opportunity to ask. That time in clinic with your oncology team is so precious, and we know that sometimes you leave and you say, gosh, I forgot to ask that question. And so you can ask Melissa. Now, this isn't to change your plan of care, but rather to ask, what exactly did this test mean? Or why are we doing a PET scan instead of an MRI? Things like that. We're full of questions. And so Melissa will help you with those questions. And then about 2 years ago, because many of these questions were the same, she started doing a series of webinars called From the Clinic to the Living Room, where she takes these same questions that people have asked again and again, and she does videos on them. And so I can't, recommend those to you enough. And then we have these symposiums. AIM at Melanoma co-hosts 10 a year across the country. So I want my new friends at Johns Hopkins to forgive me for forgetting for just a moment this morning where I was, because we do these with wonderful researchers all across the country. It's important to us that you have the hot off the press research information to inform you patients who are better informed, make better choices for their care. What do we do with this information? Well, we take these presentations, we divide them by topic, and then we put them back on our website. So the same place that people went to register for this symposium, they can go in there about 2 weeks and they'll be able to see them. But you don't have to wait. In addition to that, today, about 20 minutes after we close, our symposium in its entirety will be available at Aim at Melanoma's YouTube site. So you can just go in there onto our live page and you can watch the entire symposium again and send it to people in your family, those that you love or you work alongside of, that would benefit from this information. And don't worry, you say, how am I going to find that? I'm going to send you an email in about an hour that has that link, so you know exactly where to go on YouTube so you can get this information. I also want you to know about our podcast. Stephanie spoke so eloquently about, cancer is something that impacts individuals. It's not just a physical experience, it is an emotional experience. When somebody says that you have cancer, it's a deep emotional experience. And so we have a wonderful podcast called Beyond the Clinic, and it's hosted by Sam Siegel, who herself is a cancer survivor, and we call her Dr. Sam. And she believes in vitality from the moment of diagnosis. That's what she talks about on our podcast. And so she has wonderful experts, but a lot of the experts are survivors. So join us and listen to Beyond the Clinic, where you're going to hear about, building a support community, or what it means for vitality from the moment. Let's not give up those things that bring us joy, because cancer walked in the room. We also have a very dense section on caregivers. Caregivers got to take care of themselves too. And so, what does that mean? And not only how do you take care of the person you love, but how do you take care of yourself? And then lastly, we have a Peer Connect program. We have a mentorship program. We have 62 adults who are melanoma survivors who have crossed that bridge and they're into survivorship. Thank goodness we have so many more survivors. We have so many survivors now. We are at a time of such hope that for the first time in December of last year, Aim at Melanoma co-hosted our first survivorship medicine symposium. 20 years ago, Val Guild could only dream that we would be able to host a symposium like that. So at any rate, for those who feel like that they are perhaps walking a melanoma journey by themselves and they would like a mentor, we also have a mentorship program. So before I get to this, I want to help you to navigate resources on our website. I'm happy for you to contact me, and we're going to put, for those of you online, and we're going to put my email address and also Aim at Melanoma's web address on there, and so you can reach out to us for support. For those of you who are here, I would be happy to give you my card. But I also want to tell you about one more thing. About 18 months ago, the non-melanoma community reached out to Aim at Melanoma and said that they would like some of these same resources available to you. So we have a website called Aim at Skin Cancer, and there you can find the same resources, the same type information that's available at Aim at Melanoma, but for folks who have non-melanoma skin cancer. And so with that, it's time for our question and answer. And thank you so much. Thank you for joining us.
All right, thank you, Ann. If I could have all the presenters join me up front, we're going to do a quick Q&A. I'm just going to pass this back and forth between. Is that working? Great. All right, let's begin at the beginning. This first question is for Dr. Gerstenblith, and it says, lesions that are found to be atypical after a local excision, should they follow the same kind of surveillance? So sometimes somebody gets a biopsy of a skin spot, and the pathologist says this is atypical. Dr. Gerstenblith, what does atypical mean, and what should somebody do about that?
Okay, thank you. Great question. And it, of course, depends really what the pathology report says. because there's a range of atypical findings that might be reported, from a mole being mildly atypical or moderately atypical to a mole being called severely atypical or dysplastic, to even something that is really a borderline melanoma lesion. So something that might be called atypical intraepidermal melanocytic proliferation. And dermatopathologists who read these biopsies sometimes use different language depending on sort of what institution they're part of. So really it is a conversation with the dermatologist to understand what that atypical mole means and sort of where it falls on that spectrum of either being mildly atypical, which mildly atypical or mildly dysplastic nevi are very, very common, to severely atypical or even approaching sort of another pathologist might actually call that a melanoma. So let's treat it like a melanoma. So it kind of depends. For just a run-of-the-mill mildly or moderately atypical mole, that is thought to not really be a precursor of melanoma, but to be a marker of somebody who is at risk for melanoma. So we would usually recommend a once-a-year skin check. If they have a lot of moles or they've had many atypical moles removed, we might recommend twice-a-year skin checks. But usually the skin check frequency is not quite as intense as it is for patients with melanoma, unless that atypical lesion is much closer to melanoma, if that makes sense.
Okay, thank you. You can pass the mic to Stephanie. This next question's for her. So Stephanie, this question is about the way that side effects are described in the setting of medications. So what does a common toxicity mean? What does a rare toxicity mean?
It's a good question. And that's where we as pharmacists try to not scare you, right? If you read the product label of medication, I don't think you would ever put any medication in your mouth because the list of side effects is overwhelming. When we say common, that generally is referring to greater than 20% of patients experience it. So if more than 1 in 5 patients given this medication will experience this toxicity, that's something that I'm going to talk to you about extensively because I think that's likely to be something you could experience. I'm also going to go over the rare side effects. Those are ones that are on the scale of 1 to 5%, sometimes less than 1%. I mentioned pneumonitis or inflammation in the lungs. That is a side effect that with the BRAF targeted agents and MEK inhibitors can happen in like 1% of patients, but it can be lethal if not identified, right? So if there's something that you as a patient need to report to us promptly in order for us to take action so that we can make sure that it is not a lethal toxicity, that's also going to be something that we talk about. So we try to give you a framework of what you're likely to experience. But then I always end every counseling session with the caveat that you're an individual. If it's something that is new that you've experienced, once you started taking the medication, talk to us. We can see if it's potentially related. And we have things that we can do to mitigate those side effects, whether that be dose reductions or other medications that we can prescribe. So I don't want a patient to stop taking a medication because we didn't even know about a side effect that they were experiencing.
All right, thank you very much. This next question regards TIL therapy, TIL. TIL is an acronym that stands for tumor infiltrating lymphocytes. And we need at least 2 people to answer the next question because this therapy involves the surgical removal of a tumor from the patient's body and then some fancy processing of that tumor. And then we give the cells, the immune cells that were in that tumor right back to the patient. And we ask those cells, which are now angry, to fight against the melanoma. So Dr. Lang, let's start with you. Who is an appropriate candidate for TIL therapy? When would it be a good/safe choice for a patient?
Well, in terms of choosing a target,
Closer.
in terms of choosing a target. So the size matters and the viability of the cells matter. So we want to ideally remove a piece of tumor that is between 1.5 and 4 centimeters. That's sort of the ideal size to subsequently get the correct amount of TIL out of. It also should be something that is accessible without substantial morbidity, the patient should be able to recover from that operation relatively easily so that several weeks later, they're in good shape to receive their treatment. And it should be a target that is active, a target that is not necrotic. Sometimes you can tell on the imaging that a tumor has turned partially necrotic. That's probably not a good target. We also know that some areas are better than others. The best site for making TIL appear to be involves lymph nodes. So there are a lot of different factors that we think about when thinking about, is somebody a candidate for resection to make TIL? And if so, what's the best target?
Excellent. Thank you. Part 2 goes to Dr. Warrior.
In terms of who is an ideal candidate for TIL, there are a few considerations that go into this. One is time related and one is diagnosis related. In terms of the time, a TIL process itself takes several weeks. So there is a surgery that is up front. There's a preparation of the cells that is required, and that can often take on the order of 6 to 8 weeks. And that may, to some seem like a short amount of time, to others may seem like a long time, but that is an eternity if someone has already gone through a couple of the commonly approved treatments. And so therein lies a big question of what is that patient going to receive while they're waiting for those TIL cells to be prepared. The second aspect of this is, what is the state of their melanoma? That also relates back to the time. If the melanoma is in a state where it is rapidly growing and it is a large tumor that might cause some organ compromise in the very near future, that may not be the ideal person to go through the TIL therapy process for a variety of reasons. But those are two major considerations, and there are several more besides. So we are very selective, and we want to offer this to as many patients as may be appropriate, but we also want to be very considerate and not cause more harm than good.
All right. Thank you, Dr. Warren. The next question is for Laura and for Megan, and the question surrounds when we are referring patients to our colleagues in counseling and in integrative health. When are we doing that, and what are we asking them for help with?
So we can do this at any point in time during treatment. We, as social workers, we don't see every patient. We get consulted to see patients. So it's typically once a problem area has been identified by someone else in the clinic, or if a patient asks to see us. Sometimes patients just call us as well. So that would be kind of the beginning point. It's really up to the patient for when they would get to us for counseling. And it's the same for our psychiatric nurse liaison. Is typically patient driven for if and when they would want to see that person.
What sorts of things are we addressing when that happens?
Well, it depends on what the patient problems are. So I'm doing a couples counseling right now with someone who they're just figuring out how to adjust to what we call the third roommate in their house, which is the cancer diagnosis. And so those types of things on how to live your day-to-day life with cancer, with your treatment, with figuring out your new normal for how you feel on and after treatment as well. Depression, anxiety, we use a lot of cognitive behavioral therapy approaches, problem-solving therapy approaches. Since we are clinical master's level social workers, we use a lot of things that we know are evidence-based.
Great. And then same question, this is for Megan, same question for integrative health practitioners. When do we refer, and what are we asking them to do? What circumstances would make us refer to an integrative health practitioner?
I think this is also something where it's patient-led. So a patient will ask us about a certain supplement, a certain side effect they're having. Would acupuncture be helpful? What are the risks and benefits of doing an quote unquote alternative therapy? At Hopkins, we have a provider, Taya Lee, who works in oncology, who can help guide that. So I often refer patients when they are coming in with, I want to address this problem with this supplement, or is there a way to address my neuropathy without medications that would cause side effects, which might be acupuncture or something. And so they could weigh the risks benefits of some alternative therapies. Would they really help or not, and do it in a safe way?
Great, thank you. All right, Dr. Warrior, back to you. Immunotherapy in the setting of a resected stage to melanoma. Talk about why we might recommend that and how we balance the efficacy of that drug with the side effects that it might bring.
Yeah, this is a great question. And I think out of all of the patient populations, even within melanoma that we see, I find this to be one of the most challenging conversations. And I say that because there is a lot of personal preference and risk assessment, I think, that goes into this. So I always tell my patients, I'm here to give you the information so you can make the right decision for yourself, and we can guide that process along. We heard a little bit about this from Dr. Scharfman, and that is the risk and the benefit. In stage 2 melanoma, the high risk one, stage 2B and 2C, there is a very decent chance that that patient's going to do well without any additional treatment. In fact, more than half of patients will not have their melanoma come back. There is certainly, has been shown in clinical trials, to be a benefit to some in the overall population of giving the 1 year of immunotherapy. That comes with that risk that Dr. Scharfman mentioned of that 10 to 15% chance of really having a serious side effect, a life-altering toxicity. And so I think we have sort of both ends of the spectrum that walk through our door and everyone in between. We have some patients that come in and say, I just went through an awful lot with my melanoma and surgery and everything else, that's enough. And if there's a good chance that I don't have to deal with this again, I'm done, right? Just give me the scans and I'll do the monitoring. There are other patients who walk in the door and say, I can't sleep at night unless I know that I'm doing everything actively that I can do to try to keep this melanoma from coming back. And a lot of people fall squarely in the middle. So for some, we'll review the data in detail. For others, we'll just talk about sort of what feels right or what you might regret, sort of if you take a look back. But this is certainly a challenging conversation. We are certainly over-treating some proportion of people who will not have the recurrence, but may experience side effects. This is where, just to tie this into some of the research we're doing, where if we can develop those blood-based monitoring approaches or other things to try to predict who is more likely to recur, maybe we can spare some patients, the unnecessary use of this type of treatment while giving it only to those who need it.
Great, thank you. Dr. Gerstenblith, will you talk a bit about how melanoma looks on skin of color?
Sure. So in people with skin of color, the most common presentations are not really always sun-exposed sites. So we can see the acral lentiginous melanoma. So that's the one that can show up on the palm of the hand or the sole of the foot or in the fingernail. And so that certainly, occurs, and we want to target our education to sort of all patients who have a risk for melanoma. So that's kind of the most common location. So it can be normal for people with darker pigmentation to actually have sometimes lines of darker pigment on the nail bed. So sometimes telling what's normal versus abnormal, you might have to see your dermatologist to tell that. But yes, it can certainly happen. And that type of melanoma can occur in all races.
While you're holding the microphone, does having basal cell mean that you need to be concerned about getting melanoma?
So it's a good question. So having any of the 3 most common types of skin cancers, basal cell carcinoma being the most common, squamous cell carcinoma being the next most common, and then melanoma being the 3rd most common, having any one type of those does increase your risk for the other of those 3 types. So when patients have had a basal cell carcinoma, they can have that treated. Usually it's a pretty easy surgery if it's found at a relatively early stage. And but we sort of say, okay, you need to come every 6 months or at least once a year because you are at increased risk for another basal cell showing up somewhere else or squamous cell or melanoma. So yes, and that's because those 3 most common skin cancers share a lot of the same risk factors. So fair skin, easy, poor tanning, freckling, that's all shared among those 3.
Okay, great. So we have 2 questions that involve side effects. The first is for Stephanie. We're going to talk about efforts to improve the toxicity profile, and then we're going to turn to Megan about using our subspecialists to help us manage some of the side effects. So Stephanie, the question is this. This patient was on vemurafenib and cobimetinib, which is a dual oral therapy. A year ago, 10 days after starting treatment, experienced a very serious side effect from those therapies. Are there studies currently underway to improve the safety of the available treatments or to identify patients that are more likely to to experience those side effects?
It's a good question. I think certainly with the 3 combinations that we have available for targeting BRAF and MEK, if the patient has not progressed, so it sounds like this patient's cancer, they just couldn't stay on the drug for whatever reason. I don't have a lot of details, but we can move from one couple to another couple, depending on what the side effect is. If it's not believed to be a class effect, even if it is potentially a class effect, we can see if starting at a lower dose of another agent would be beneficial. With drug development, there is a push to try to make newer generations of drugs that are able to overcome some of the resistance mechanisms, right? So with targeted therapies, one of the reasons why immunotherapy is a little bit more attractive sometimes is that the immune system, while it can also develop resistance and ways for the cancer can find ways to grow around it, targeted therapy kind of drives that a little bit more quickly. And so newer generations of drugs are constantly in development that are looking at ways to overcome resistance. I'm not the best person to talk about pipeline. I don't know if Dr. Warrior could with that, but I think the key take home here is that I wouldn't necessarily in this particular case write off BRAF MEK inhibitor therapy because we do have 2 other drug couples available. I would need more details to find out what exactly the toxicity was, but there's something we could probably do with either trying one of the other pairs or starting at a lower dose and titrating up, right? We don't start every patient off at full FDA approved recommended dose. Sometimes we will start low and we'll go slow. The other thing is that sometimes we can do different things with the BRAF inhibitor versus the MEK inhibitor, depending on what the side effect is. So if we know which of the 2 agents is driving the toxicity, we can be a little bit cautious with that particular drug. And in particular with dabrafenib, trametinib, I have seen patients tolerate and have their cancer be controlled on much lower than the full starting dose, right? So I think that's another component of drug development is that the FDA is pushing more for dose optimization with their Project Optimus. So what they're trying to do is they're trying to find what is the most clinically effective dose, but also a well-tolerated dose? And is there a lower dose that is just as clinically effective, but is potentially better tolerated? So I think those types of questions, which are important for patients and meaningful to patients, are the types of things that we're starting to look at as new drugs come to market.
Great, thank you. So in related news, there's a sort of a 2-parter. So first question is, do side effects from immunotherapy and efficacy of immunotherapy go together? And then the second one talks about drug-induced arthritis. In this case, it's BRAF/MEK, well, immune therapy as well. This question involves going to see a rheumatologist and getting on methotrexate for the arthritis. So could you talk a little bit about how we partner with our subspecialty colleagues to help in managing some of these side effects?
Sure. So, sorry, can I see the first question again?
Side effects and efficacy.
Yeah, there seems to be a correlation between some side effects, dermatitis, inflammatory arthritis, thyroiditis, and efficacy of therapy, meaning that it works better. However, it is not a causation. It doesn't mean that I have people who get side effects and don't respond, and people who don't have side effects and do respond. So it's not true in all cases, but there is a correlation. So BRAF inhibitor arthritis and immunotherapy arthritis are 2 different entities. But in general, the toxicities can get quite complicated. In our medical oncology clinic, we try to start off with something low side effect. Sometimes you're plugging holes in the dam you have one medication causing a side effect and you start another medication like high dose prednisone that causes a side effect. So we try to start off with something that to treat an immunotherapy toxicity side effect that won't cause another side effect. But if we're not doing what we need to do to control the side effects in our within our expertise in oncology, we are getting people into subspecialty clinics. You saw the list of itises out there. There's a lot of them, and there's a subspecialty for all of them. So we have a rheumatology colleague who works out of Bayview that I refer many patients to. We have endocrinology colleagues that we are referring to for the adrenal insufficiencies, the thyroid issues that we can't get a handle on. Dr. Kirsten Bliss sees a lot of our dermatitis. Sometimes we'll try some topical steroids, some antihistamines, but if people are still awake itching at night, we really need to think about other medications. And so basically we are getting people into, subspecialists to really evaluate what drug would be best for them.
Great. Thank you very much. We are almost out of time. I did want to address a few questions that are overlapping. One of these involves a question about, is Hopkins doing any research on the gut microbiome, its influence on immunotherapy? There's another question here about rare melanoma subtypes, acral melanoma, uveal melanoma. Do we see lots of those patients? So the answer generally to those really in the weeds questions is yes. Hopkins is doing research on acral melanomas. And yes, we are looking into relationships between the microbiome, the bacteria that live in your gut, and whether immunotherapy works. I would encourage you to send your questions to AIM at Melanoma or to us and begin those conversations. There is a lot going on at the Johns Hopkins Melanoma Skin Cancer Program that we didn't get to talk about today, but we would be glad to in the future. So we are, as I say, out of time. So I thank you all very, very much for being here. It was a real pleasure seeing you. And we hope to do this again at some point in the future. So thanks again.